One. Sir, please start. We are live.
Hello, good morning, everyone. It's a pleasure to welcome you all for this special update on breast cancer management. New data, new update, new year. Uh, this update is done under the aegis of SOMEX Research and Health Organization, and it's a pleasure to welcome the session coordinator, Dr. Ankit Mehra. Dr. Ankit, good morning to you. Dr. Ankit is a consultant medical oncologist at SCG Hospital, Jaipur. We look forward for your welcome and introduction and setting the context, please. So, Dr. Ankit, over to you, please.
So first of all, thank you Somani sir and the organizing team to giving me this opportunity. And good morning and very warm welcome to all in this all the chairpersons, speakers, panelists, and the participant in this very breast cancer update session. And for our first session, I would, as a chairperson, I would like to call Dr. G.S. Bhatti sir, who's a senior professor in the Department of Medical Oncology, Umaid Hospital, Jodhpur, and Dr. Surendra Beniwal sir, who's a professor in the Department of Medical Oncology, PBM Hospital, Bikaner. So for our first talk, I would like to call Dr. Somani sir for the talk redefining the management of HER2 negative early breast cancer in the era of precision medicine. To Somani sir.
Dr. Beniwal, would you like to say something?
Good morning to everyone. First of all, I would like to give thanks to Somani sir, who is always loves academics, and also he forced us to learn something, and he will arrange such type of great meeting, I think 4 or 5 times in a year. And I will, as already Dr. Ankit said, I will like to invite you, sir, for the session. And you doesn't need any introduction, but as a formality, I will like to introduce you. Somani sir is the director of oncology department and head of the Department of Medical Oncology at SCG Hospital and Somani Hospital. And now he will give his talk. Thank you.
Mr. Tarun, can I start sharing from my end? Yeah. So is my screen visible now?
Yeah.
Yeah. Thank you. Good morning and welcome you all once again. So the theme of the meeting is by us, for us. It's basically the meeting keeping in mind all the consultants, faculties of the Rajasthan Oncology Group. And I'm thankful to all of you that you accepted the invitation and you accepted to be the part of the meeting. So I always keep in the mind that we are now enough in numbers and we are now having the enough maturity and the experience that we can run the meeting ourselves to have the better interaction with each other so that we can understand our patient's problem, their requirement, our scientific requirement in much better way. So coming to my topic, I will be basically highlighting few of the points in the management of the early breast cancer HER negative patient and few of the recent advances which have come in the last few months or so, and especially in the context of the SABC that I will be basically presenting. So we all know that in the early breast cancer, patients remain at high risk for the relapse. Typically, HR positive or triple negative breast cancer, which are HER negative, especially those patients where the tumor is more than 2 centimeters, we try to give them the neoadjuvant hormone therapy or chemotherapy, and then depending on the response, we go for the breast conservation or mastectomy followed by the radiotherapy local site depending on the criteria, and then continuation of the chemotherapy and the hormone therapy as applicable. So this is in a nutshell the theme of treating the patients at present. Now coming to the BRCA mutation, we all know that the incidence is not so high, but the available reports, especially from the India, say that the BRCA positivity is variable, but it is comparatively higher in Indian patients' context compared to the Western data. So that becomes more important for us. Now, why BRCA is important? The patients are diagnosed at the younger age in the BRCA group. The BRCA tumors are of higher grade. there's a more chances of the CNS metastasis and more chances of the contralateral or the recurrence of the ipsilateral disease in this particular group of the patient. Now, in the context of the early breast cancer setting, the decision of the BRCA is very, very important to take it the earliest possible. It can influence the management of the surgery. So we need to have it before surgery, and at least we should have it in the before we start the adjuvant treatment, because these two points decide us that what kind of the treatment, depending on the BRCA, we are going to give to our patients. Now, in this context, the Olympia A trial has recently given us the more insight about this. Particularly, the eligibility criteria for Olympia A trial were high-risk BRCA mutated HER negative breast cancer, and these patients were divided in the two groups depending on the BRCA positivity, stage 2 and 3 breast cancer. They were the HER negative. They can be HR positive or triple negative, and completed local treatment and more than or equal to 6 cycles of the neoadjuvant or adjuvant chemotherapy containing anthracycline plus minus taxane. So those patients who had the neoadjuvant or those patients who did not have neoadjuvant and went for the adjuvant. So depending on the risk factors of the two, making them as the high risk group, they were randomized, and the one group was given the PARP inhibitor drug, that is the olaparib 300 mg BD versus the placebo. Now, high-risk group in the triple negative and the high-risk group in the hormone receptor positive, HER is little bit different. I will not be going in the detail, but the one thing which has come newer is the clinico-pathological score plus estrogen grouping of the patient, grading of estrogen positivity and the grade of the tumor. So based on this, total score 0 to 6 were made, and those patients who were on the high-risk group, based on this, especially in the HR positive patient, they were labeled as the high risk for the chances of the relapse. Now, in this particular Olympia A trial, if we look at the primary endpoint, that is the invasive disease-free survival, we see that at the end of the 1 year of the treatment and then subsequently, invasive disease-free survival is in favor of the study arm, that is the olaparib arm, compared to the placebo, and that is to the tune of 5 to 6%. Now, this benefit, the most important thing is that this benefit is consistent across all the groups, whether the patient received neoadjuvant versus adjuvant, whether the platinum were given previously or not, whether they were the hormone receptor positive or they were the triple negative breast cancer, and whether BRCA 1 or 2 or whether both, in a really broad situation where the both BRCA 1 and 2 were positive. So across all the groups, there was a consistent benefit of the PARP inhibitor drug. The recurrence risk or the death at the 3 years were consistently and significantly being less in this particular group. Now, secondary endpoint, that is the overall survival, again has shown to the benefit to the tune of the approximately 4%. So now, if you recall, when the aromatase inhibitors were introduced first time, they were accepted and they became the guideline based on this benefit of approximately 4% only. So this is how we move in the advancement of the progression-free survival and, for that matter, ultimately overall survival. So a benefit of the 4%, I think, is significant, and that gives in the favor of the PARP inhibitor. Now, various side effects in this particularly, obviously, compared to the placebo group, the PARP inhibitor will have the side effects, but these side effects were consistent with the previous data of the olaparib, and no new data were there, or nothing was new in there. Now, a similar trial, surprisingly, that is the brightness trial, where the paclitaxel, the platinum were added, and then the another PARP inhibitor, that is the velaparib, were also added, and then again the two groups were made, and these patients, when they were analyzed in the similar context, we can see here that there is no much difference by adding the velaparib in impacting or making any difference in the pathological CR, event-free survival, or the overall survival. Now, another study which I would like to mention here is does therapy with the low-dose capecitabine maintenance after standard adjuvant chemotherapy reduce the risk of the relapse and death among patients with the early stage triple negative breast cancer. So this is one of the study where the 1 year period of the low dose capecitabine was given. And the important thing is that the chemotherapy which was used initially was either CMF or AC. Taxanes were not there in this particular trial, in this particular group. And here we can see that this study was basically a negative study. The low dose, this taxane probably did not make much difference in this. Now, coming to the immunotherapy aspect, the one of the landmark trial which has come is the again the Keynote 522 trial, which is the neoadjuvant therapy with the pembro monotherapy, followed by the monotherapy as the adjuvant therapy in early stage high risk TNBC patient. So these patients were typically given like the pembro carbo paclitaxel, followed by the pembro AC, and then surgery, and then the continuation of the adjuvant pembro to make it total 1 year. Versus the placebo group where the carbopacli followed by the AC, then surgery, and then the placebo was continued. So this is the simple schema of this particular trial. And here again, we can see that the primary pathological endpoint was again consistently better, and the event-free survival analysis again to the tune of 6% was in favor of the neoadjuvant chemotherapy along with the immunotherapy, and then the immunotherapy continuation. Now, this Keynote trial with the experimental regime in an event-free survival sensitivity analysis, if we look at the various groups and the analysis points, we see that there is a consistent benefit, and all subgroup of the patient, like the nodal status based, positive or negative, overall stage of the disease, stage 2 versus 3, premenopausal versus postmenopausal, and those patients where the HER only 0 or 1, that means the beginning negative, and those 2+ followed by the FIS negative, these all patient subgroup, they were consistently being benefited by the immuno-oncology drug in the neoadjuvant setting in the high-risk patient in the TNBC group. Now, a similarly designed trial in the TNBC in early stage with the molecule atezolizumab, where the nab-paclitaxel followed by atezolizumab plus AC 2-weekly schedule was being also studied, followed by atezolizumab as 3-weekly 1.2 gram, which we commonly use. Now, this trial was also having the stratification based on the PD-L1 positivity versus negativity. If you look at the overall group, there is a difference in favor of the chemo plus IO versus placebo. And if you look at the PDL positive group only, this benefit further widens, and there is consistently more benefit compared to the negative group. Now, this particular trial, median we can see here that there is a difference, but there is a very minimal difference with the with the pembro plus in this in this particularly the IM patient, there is a difference to the tune of only 3 to 4%, particularly with this particular molecule. And important thing here to remember and to question ourselves is that we all understand the side effects of the immune therapy drug, and especially in the stage 2 or 3 patients which are highly potentially curative situation in the breast cancer, the toxicity and the attached potentiality of the death which happens in the adjuvant setting, is it acceptable to us as on today? Are we primed for that? Are our patients ready for the immune related side effects, toxicity, and the financial toxicity, and so on? So there were the few of the deaths also reported in this curative group of the patient, which is a big serious concern. And this now coming to the Monarch data. So Monarch was basically a trial where the high risk node positive, HR positive, HER negative early breast cancer, high risk means those who are high risk for the relapse. So these are the HER negative patients, those who received prior neoadjuvant adjuvant chemotherapy, nodes were positive, tumor size was more, and those patients who have completed their local treatment as well as the chemotherapy part, and they were further randomized. So the randomization was the abemaciclib 150 milligram BD up to 2 years with the standard of the immunotherapy drugs for 5 to 10 years as per applicability. Along the other group was only the standard of the care endocrine therapy. And the primary endpoint of this trial was again to see the difference in the invasive disease-free survival. Now, if we look at the MONARCH e-trial data, we see that again there is a difference of the 3 to 4% at the various points of the analysis in favor of the endocrine therapy plus abemaciclib in the adjuvant setting. So this invasive disease-free survival benefit maintained with the additional follow-up in the intent to treat population, and it remained the absolute difference in the invasive disease-free survival arms was again 5.4%. So again, I would like to reiterate that if we look at the data of the tamoxifen versus aromatase inhibitor in the beginning with the various molecules like letrozole and anastrozole, they consistently give the benefit difference to the tune of the 4% or so. So, and they got the approval. So I think that further benefit is important in the clinical setting. The safety profile of this particularly, the toxicity is more, but no new data were there. And these toxicities aspects were usually manageable in our patient. But contrast to the MONARCH, if we look at the other molecules like the palbociclib, and the two trials are there to mention in the adjuvant setting regarding the palbociclib, and sadly, these two trials did not meet in the positive way, and the data were could not show the difference. The one is the Penelope B trial, where again the palbociclib in adjuvant in the high-risk patients were being studied for, it was given for the 1 year period. And if we look at the data here, the invasive disease-free survival as well as the overall survival data, we see there is no difference, there is no statistical significant difference. And this particular molecule, based on the 1 year of the endocrine therapy plus palbociclib, could not show the difference and could not get its approval. And similarly, another trial, that is the PALAS trial, based again on the palbociclib, was being also studied with the various endocrine therapy like aromatase inhibitor, tamoxifen, plus minus LHRH agonist. And this trial was studied with the help of the palbociclib for up to 2 years. And this particular trial again did not show any difference. So we are really failed to understand that why there is a difference in the various CDK4 inhibitor. There is a difference in the trial design, duration of the aromatase inhibitor plus CDK4 inhibitor, or there is some intrinsic differences in the various CDK4 molecules. So probably the fewer further trials will be telling us. The final analysis data of this particular molecule did not markedly show any difference in the disease-free survival and so on. So it could not get any positive outcome of this. So I would like to conclude that recent developments in our understanding of the breast cancer molecular biology and heterogeneity have led to substantial improvements in the outcome. The value of identifying a high penetrant mutation like the BRCA is important now, not only for the prevention, but the treatment, including the adjuvant treatment in the early stage disease as well as in the metastatic disease. The trial like Olympia A trial reported the clinical benefits of the PARP inhibitor in the germline mutation HER negative early breast cancer, those who are at the high risk of the relapse. And the various trials of the immune checkpoint inhibitors like the pembrolizumab, particularly in combination with the neoadjuvant chemotherapy in TNBC setting, and the molecules like the CDK4 inhibitor like abemaciclib, in addition to endocrine therapy in HR positive, HR negative breast cancers, are further adding in the armamentarium treating the breast cancer. So understanding the role of these agents in the light of the existing therapy is very, very important. We'll optimize the treatment strategy in a way so that we can achieve the much better outcome for our patient. Thank you, and thanks to Chairman.
Thank you.
Okay, Ankit, go ahead.
Yeah. Yes. Thank you, sir, for this very informative and enlightening speech. Since we are ahead of time, we can take few questions if there. So I guess there are no questions. So we'll be moving forward to the next talk.
So can I ask a question to my chairman? If we are, I mean,
Yes, sir.
still have 2 minutes.
Yes,
It's
yes, sir.
unusual that the speaker is asking the question. So Dr. Beniwal represents the patient population of a wide geography region. And at one end of the state of the Rajasthan. So what does he feel that in the early stage breast cancer patient, the two things which has come like the role of the PARP inhibitor, role of the CDK inhibitor, and the and the immunotherapy. So these three things are there, I think, which are the significant development. So what does he feel looking at the population, that how sooner or later we will be having these drugs for our patients?
Definitely, PARP inhibitor, I think in our population, younger patients and triple negative patients are more, usually we are not doing BRCA1 and BRCA2, but definitely percentage of BRCA1 and BRCA2 is significantly higher for our Indian population. So if nowadays most of pharma companies give us free of coupon, so I think we have to generate our data regarding the BRCA1 and BRCA2, and if they are more positive, and we can now the generic drugs are also available, so we can also generate our data regarding triple negative breast cancer. Regarding immunotherapy, because immunotherapy is very costly drug, and I think if generic drugs are available, then we can try to establish these data at our scenario.
Thank you.
Dr. Somani, can I add to that?
Yeah.
In fact, it looks that the drugs are expensive, and of course, there are good results in particular subset of patients. So the need is that how to identify that subset of patient who will be benefited most. So one important point is like the tumor infiltrating lymphocytes, which probably our pathologists are reporting, but we are not probably focusing much on that. So I think we need to identify particular subset of patient, and other remains like the addition of carboplatin or platinum compounds in TNBC especially. So these are the practical things which is available to us, and I think we can extrapolate. Of course, if available, then immunotherapy plus chemotherapy remains very good combination. But our patients, rather than saying that affordability, or we should focus more on identifying the biomarkers to predict the response. So I think to me that remains more important for us, and most commonly we get only one chance to treatment. So we need to hit very hard, and we need to sort of plan in such a way that we offer neoadjuvant chemotherapy to this high risk patient. Most of our patients are locally advanced cancer, breast cancer. So we give them neoadjuvant chemotherapy downstage, and then plan the adjuvant treatment accordingly. But of course, whenever available, the drugs will make a good difference in the outcome also. Thank you.
In Western data, bevacizumab is not a good drug in breast cancer. But in our scenario, in our institute, we have a strategic investigator-based study. In this, we will give paclitaxel plus bevacizumab as a neoadjuvant chemotherapy in triple negative locally advanced breast cancer versus standard neoadjuvant chemotherapy followed by surgery. And now we have completed 10 patients in bevacizumab arm. We will give 4 cycles of paclitaxel plus bevacizumab, then 2 cycles of only paclitaxel, and then we will do surgery. And surprisingly, all 10 patients has complete pathological response. And the problem is that the response is so good that most of patients on bevacizumab and in group are not ready to do MRM, because they said that we have no mass, then why we will do the study. So bevacizumab may be a good drug for our such type of patients. Nowadays, bevacizumab is available in free of cost, so we can try to in our patients, in triple negative younger patients with paclitaxel.
So the BEV is allowed in the Chiranjeevi Swasthya Yojana also?
No, bevacizumab now, bevacizumab is comes in essential drugs. So bevacizumab is available free of cost to all Rajasthan patients. The patient is from Rajasthan, we can give bevacizumab even without Chiranjeevi Yojana.
Perfect. And I think in your study, this sounds very good idea, whether carboplatin is making a difference or carbo plus BEV, both are making the difference. So
I think I have also planned to, if I will success in this study, then I will try to do a study, Paclitaxel carbo only, and then with bevacizumab. One arm is with bevacizumab.
So thank you so much, Dr. Beniwal. And I think Dr. Somani has rightly mentioned that now we are good in numbers in Rajasthan. Probably second or third highest number of oncologists in Rajasthan combined together, surgery, medical, RT all together. So such studies will definitely give boost. And other could be low dose immunotherapy if somewhere ethics committee permits, or if we can plan that we give low dose immunotherapy to these patients. So whether 3 milligram per kilo or say less dose of Pembro or any other immuno-oncology drugs, can that be equally effective? Tata Hospital has done trial and probably ongoing also. So again, these are the need of R, and that remains the major idea of collating the data together of these patients. Thank you so much, Dr. Beniwal, for your inputs.
Yes, sir. Thank you, sir, for the valuable inputs. Moving on to the next talk, I would like to call Dr. Tarashan Gupta, sir, a consultant medical oncologist at Bhagwan Mahavir Cancer Hospital and Research Center. He'll be talking about aromatase inhibitor versus tamoxifen in premenopausal women with estrogen receptor positive early breast cancer treated with ovarian suppression. Over to sir.
Thank you, Ankit, and thank you, organizers Somani sir and Jitendra, for giving me the opportunity. So after a talk on very new molecules, higher molecules, and now returning towards the very basic oncology, which is we are practicing from the beginning, also we can say. So we are going to discuss for a very basic question that aromatase inhibitors or tamoxifen, which is better with the ovarian function suppression in premenopausal women in adjuvant settings. So this is the early breast cancer trialist control group study. It was done, and that was presented in December and group. So basically discussing the tamoxifen reduces the 15-year breast cancer mortality by 1/3 in ER positive disease, according to the study published in the Lancet 2011 by the EVCTC. And aromatase inhibitors are even more effective in postmenopausal women than tamoxifen. And AIs may benefit premenopausal women when we treat with the ovarian suppression along with the AI. So this is the hypothesis and background. So method was used a meta-analysis of individual patient data for 4 trials of premenopausal women with early stage breast cancer treated with ovarian function suppression, randomized to aromatase inhibitors or tamoxifen. Primary outcomes were recurrence and cause-specific mortality that was analyzed by the standard EBCG method, which was published in 1990. And for that, for the primary outcomes, statistically significant p-value was kept at 0.05 less than, or for the subgroup analysis, the significance was decided for the p-value of less than 0.01. So these 4 trials were included in this meta-analysis. ABCSG trial, which started in the 1999, and text, soft and hover trial that used abstract ABCSG all used the triptorelin as a OFS, but then ABCSG it was goserelin was used, and in ABCSG anastrozole versus tamoxifen, while soft text used the exemestane versus tamoxifen, and however triletrozole versus tamoxifen. So all trials give the endocrine therapy for 5 years in early breast cancer, except the ABCSG.
Sorry to interrupt, but we can't see your slides.
Now you can see the slides?
No, sir.
No, sir.
No?
No, sir.
1 minute.
Who is sharing the screen? I think you are not sharing your screen.
Now?
Yeah.
Yes, sir.
Yes, sir. Yes, sir.
Sir,
Just make it full screen, sir.
मैं अपनी धुन में था, मैंने शेयर किया, स्टार्ट कर दिया. Sorry.
Sir, just make it full screen, please.
Now it is okay.
Yes.
So again, so we are, I think we are discussing the aromatase inhibitor versus tamoxifen in premenopausal women with ER-positive early-stage breast cancer treated with ovarian suppression. A patient-level meta-analysis of 7,030 women in 4 randomized trials. So going in the background, tamoxifen reduces the 15-year breast cancer mortality by 1/3 in ER-positive disease. Aromatase inhibitors are even more effective than tamoxifen in postmenopausal women, again by the ABCTCG group, and AIs may benefit premenopausal women treated with ovarian suppression. So in this meta-analysis, the individual patient data was collected for the 4 trials of premenopausal women with early-stage breast cancer treated with OFS and randomized to AIs versus tamoxifen. So primary outcomes were recurrence and cause-specific mortality analyzed by the standard EBC-TCG methods. The p-value for the primary outcomes was less than 0.015 for the significance, and for significant subgroup analysis, the p-value was kept less than 0.01. So these 4 trials were included in this meta-analysis: ABCSG, TAXSOF, and HOVER trial, in which the ABCSG used the goserelin, rest 3 trials used the triptorelin as the OFS, and all they used the AIs, anastrozole, exemestane, and letrozole. And all the trials you gave the endocrine therapy for 5 years, except ABCSG, which used the 3 years. And this was the follow-up data. And if we see the patient's characteristic, we can see the 75% patients in ABCSG were the node negative, while rest patients in the test it was 52%, and SOF it was 65%, and 55% in HOVER trial. In the ABCSG, it was the ER positivity kept by the more than 10%. Rest 3 trials used ER positive staining more than 1% of the cells. So chemotherapy used in these trials were ABCSG allowed only the neoadjuvant chemotherapy. Adjuvant chemotherapy was not allowed in this trial, so only 5% patients received any type of chemotherapy in ABCSG. While text trial, it was optional, and around 60% patients received the adjuvant or neoadjuvant chemotherapy. And this, if the patient was receiving chemotherapy, then triptorelin was given at the start of the chemotherapy, and then it was AIs were added after the completion of the chemotherapy. And if the chemotherapy was not used, then the AIs were started after the 6 to 8 weeks of the ovarian function suppression. So SOF trial also before randomization, but patient had to remain premenopausal after completion. So 54% patients received the chemotherapy, and in this HOVER trial, they received the 63% patients before the randomization received the chemotherapy. So according to the primary outcome, the recurrence we see in the all the meta-analysis, that we can see that at 10 years it was the 17.5% patients has recurrence in tamoxifen arm, while 14.7% patients have aromatase inhibitor arm received the had the recurrence. So it was around 2.8% difference at 10 years, but while it was so it was significant value, and while at 4 year or 5 year it was 10.1% versus 6.9%. So the maximum difference was observed between the 0 to 4 years, and after that neither the benefit was lost or not added benefit was observed in this recurrence score. And we can see this the forest plot chart also, that after the age 5 there was no additional benefit was observed in recurrence score. For the distant recurrence, there was distant recurrence was also significant at 10 years. It was 10.1 versus 12.2% in the tamoxifen versus aromatase inhibitor, and it also remained nearby same from the 5.6% versus 7.1% at 5 years. For the breast cancer mortality, it was not affected by the aromatase inhibitors or tamoxifen use. It was nearby same in both groups with overlapping of the curves we can see. So it was this was another finding in the breast in this trial, which showed there was no survival difference of the aromatase inhibitor over tamoxifen. The rest only 30 analysis investigated in possibilities variability was this checked. So proportional reduction in recurrence did not vary by age, BMI, tumor size, tumor grade, histological subtypes, or presence or absence of chemotherapy. This was the post-hoc subgroup analysis of any recurrence. So we can see that the N0 to 1 to 3 lymph nodes positive disease, all the patients showed the significant benefit with the addition of with the aromatase inhibitor as comparison to the tamoxifen. But surprisingly, it was not seen in the 4 or more node positive disease. That may be a chance finding, I think, because it was observed in the other postmenopausal groups also. And if the HER2 status, we see that the most of the benefits were in HER2 negative and not the HER2 positive. And but if we go with the subgroup analysis, P very significant, then it was not significant. So this can be also explained as a chance finding, because another trials of the postmenopausal study of the EV-CTCG did not show the difference between the HER2 positive or HER2 negative treated with the aromatase inhibitors. In the N0 disease, it was the recurrence benefit was 11.7, recurrence score was 11.7% in tamoxifen arm versus 9.3, and aromatase inhibitors at 10 years, while at 5 years it was 3.2 versus 6.3%, and same benefit with the 20 in around the 29%, it was 70% relative risk of the 1 to 3 lymph node positive disease. This was remains same. Yes, bone fracture.
Dr. Tarajan, sir, 2 minutes to conclude.
Yes, sir.
Okay, yeah, bone fractures were more in the aromatase inhibitor arms, rather than tamoxifen arm. It was 3.8 versus 5.0%. While it should be clear that bisphosphonates were not allowed or not given in the trial except the EV-CSG group, that was balanced. Other than or rest trials did not use the bone bisphosphonates. And non-breast cancer deaths were also similar in the both groups. To conclude, this meta-analysis showed the reduction in recurrence rate following aromatase inhibitors over tamoxifen. No difference in breast cancer or all-cause mortality between the two treatment groups might be explained by the limited duration of follow-up, because the EV-CTC group, another study in the 20 years of follow-up, which was published in NEJM, that showed the recurrence was score was same. So this showed the importance of the longer follow. So given it was only the 8-year follow-up, so survival benefit could not be observed. Given the significant reduction in the distant recurrence with aromatase inhibitor, it would be premature to conclude that survival is not improved with the aromatase inhibitors. Subgroup analysis also suggested greater benefit from aromatase inhibitors compared with tamoxifen for any recurrence in HER2 negative disease than in HER2 positive disease. But it may be a chance finding only, because this was not observed in the postmenopausal women also. The most unexpected subgroup finding was the apparent lack of superiority of aromatase inhibitors over tamoxifen with women with 4 or more involved nodes. Results from this meta-analysis suggest that using an aromatase inhibitor rather than tamoxifen in addition to ovarian function suppression for premenopausal women reduces the absolute risk of recurrence by 3% at 5 and 10 years. There was no increase in non-breast cancer death over 10 years follow period. The effect of endocrine therapy and ovarian function suppression on quality of life also need to be carefully considered in the scene of the bone fractures. So now I conclude my presentation or topic.
Thank you, sir. Thank you for such an excellent talk, sir. For next talk, I would like to call Dr. Mukesh Rolania, who is Assistant Professor, Department of Medical Oncology in Bone Marrow Transplant, State Cancer Institute, Jaipur. He'll be talking about taxanes with anthracycline versus taxanes without anthracycline, individual patient level meta-analysis of 16,000 women with early breast cancer in 13 randomized trial. Dr. Mukesh, over to you.
Good morning to organizing team, Ankit Bose and Somani sirs. My slides are visible now?
Yes.
So today's my little bit controversial topic, taxane with anthracycline versus taxane without anthracycline. This meta-analysis presented in this last year SABCS. So what is the background of this meta-analysis? As we know, anthracycline and taxane-based chemotherapy for early stage breast cancer reduce the risk of breast cancer mortality by about 1/3 compared with no chemotherapy. But especially concerns about toxicity of anthracyclines, we know that there is multiple cardiovascular side effects and long-term chances of development of leukemia, and with taxane there is chances of neuropathy. So recently there is increasing use of non-anthracycline based chemotherapy, especially in HER2-positive breast cancers. So methods of this meta-analysis to aims is to better characterize the benefit and risk of anthracycline and taxane chemotherapy for early stage breast cancer in adjuvant setting. This meta-analysis of patient level data included eligible randomized trials that started before 2012. All trials included at least 6 cycles of chemotherapy in each arm, and primary outcome was recurrence and cause-specific mortality analyzed by standard ABCT-CG methods. So these 4 subgroups are compared in this meta-analysis. Group A included 3 trials, which compares 6 cycles of concurrent anthracycline docetaxel with cyclophosphamide versus 6 cycles of same dose docetaxel plus cyclophosphamide. Second group which included sequential anthracycline taxanes versus higher cumulative dose docetaxel plus cyclophosphamide. Third group containing taxanes plus anthracycline versus higher cumulative dose taxanes with or without capecitabine. And fourth group include taxanes plus anthracycline versus higher cumulative dose of taxanes plus carboplatin. So from all studies, combined analysis of 16 trials that shows that relative risk of recurrence decreases by 15% in taxanes with anthracycline arm as compared to taxane only, and this is statistically significant. And if we go for breast cancer mortality, also 13% relative risk decrease in mortality also with anthracycline with taxane as compared to taxane alone. And 10-year absolute benefit in recurrence is 2.5% with taxane with anthracycline as compared to taxane alone. And 10-year breast cancer mortality benefit is 1.6% with taxane and anthracycline. So trial comparisons according to group A to D, this is forest chart that maximum benefit is concurrent taxane with anthracycline, which reduces the 42% relative risk of breast cancer recurrence as compared to sequential or other groups. So this is distribution of hormone status, nodal status, and HER2 positive. Maximum patients are hormone positive in group A and group B, and also maximum have node positive. Relative distribution of also HER2 positive patients. And we saw the taxanes with anthracycline and docetaxel plus and cyclophosphamide. We compared group A and B, and in this group A, they show that cumulative anthracycline dose is 300 and cumulative docetaxel is 450 in both arms. And with sequential anthracycline plus taxanes, they show that epirubicin cumulative dose utilizes 300, but they utilize higher doses of docetaxel 450. So if we compare group A and group B, concurrent versus sequential, we show that concurrent regimen is far superior as compared to sequential regimen, and the concurrent regimen decreases 42% relative decrease in breast cancer recurrence as compared to taxane alone. With 10-year gain is 8.7%, and with sequential regimens, there is only 8% relative risk in decrease, relative decrease in the recurrence, and 10-year gain of absolute is 0.6% only. So this is breast cancer mortality comparing group A and group B. In concurrent group, there is a 35% relative decrease in mortality, and in sequential only 9% decrease in mortality. So according to hormone status, there is more benefit in ER negative as compared to ER positive with anthracycline regimens. According to nodal status, and this forest plot showing that there is no specific benefit according to the nodal, because all patients on node negative or node positive patients are benefited from anthracycline regimens. So we come to toxicity and quality of life, and this analysis showed that no statistically significant difference in death without recurrence, and no difference in death from cardiovascular disease or leukemia, but longer term follow-up is required at present. And individual patient level data on quality of life and toxicity is not available. So conclusion from this meta-analysis show that 15% proportional reduction and 2.5% absolute reduction at 10 years in the risk of invasive recurrence for anthracycline plus taxane versus taxane alone. But much larger proportional reduction seen with concurrent schedules, taxane dose same in both arms, and the only difference was the addition of anthracycline in concurrent schedule. Little if any benefit in trials of sequencing anthracycline taxanes versus higher dose taxane in the control group. If you use higher dose taxanes and then use sequencing, then it's little bit benefit. And there is a proportional reduction in recurrence, did not differ by ER status or nodal status as I discussed. Thanks.
Thank you, Mukesh, for a very crisp and informative session. Now, before ending this session, I would like to call Dr. Surendra Beniwal, sir, to give a excellent comment on this session.
Thank you, Ankit. With ending of this section, we will also nowadays got very much higher population of early breast cancer. So it's time to generate our data. We all are very good in strength, so we can come together and we can also generate our data, and we can implement these data with some modifications to our need, and we can implement these data to at our patients. So thank you very much to all of us for giving such type of informative lectures.
Thank you, sir. Thank you, sir. We are 2 minutes ahead of time, so if there are any questions, we can take it. Otherwise, we'll forward to the next session. So we'll be moving forward to the next session, but an excellent session it was. So for second session, I would like to call Dr. Sumita Jain, ma'am, which is a Senior Professor, Department of General Surgery, SMS Medical College, Jaipur. Dr. Raj Govind Sharma, sir, which is Senior Professor and Head, Department of Surgical Oncology at Sri Ram Cancer Center, Mahatma Gandhi Medical College and Hospital, Jaipur. And Dr. Shantanu Sharma, sir, who is a Consultant Radiation Oncologist at SMS Hospital, Jaipur. And for our first talk, I would like to call Dr. Nitin Kundeta, sir, who is a Unit Head and Senior Consultant, Department of Surgical Oncology at Sri Ram Cancer and Super Specialty Center, Mahatma Gandhi Medical College and Hospital, Jaipur. So Dr. Nitin Kundeta, sir, will be talking about redefining the auxiliary management of after neoadjuvant chemotherapy. What does the evidence support? Dr. Nitin, sir, over to you, sir. I think.
Morning, everybody. And can you just switch off the previous slide sharing so that I can start my slides?
Dr. Mukesh, please remove your screen. Sir, please stop sharing.
Yeah. My slides are visible there?
Yes, sir. Yes, sir.
You can go on the full screen. Nitin, you can go on the full screen, please.
Thank you, boss. So today's discussion, this lecture was discussed there in San Antonio conference, and defining the auxiliary management after neoadjuvant chemotherapy, and what is the new evidence for it has been shown here. So auxiliary surgical management in early breast cancer, as we all know, in early breast cancer, it was previously auxiliary lymph node dissection, and now with over the new techniques and the new results that we have, and because of NSA-BP-B4 trial, which has shown a survival benefit of sentinel node biopsy. So in early breast cancer, it is a standard of care to go for an early sentinel node biopsy in early breast cancer.
Sorry to interrupt you, sir. Can you please can you make the slide sharing mode, sir? Slideshow mode.
Yeah, it is.
It's not moving.
We are on the first slide only, sir. Till now, we are not able to see the second slide.
Is it now?
Yes, sir. Yes, sir. Now it is there. Yes.
So what axillary lymph node dissection gives us is a local control of the disease in the axilla and provides staging information. But as NSA-BP-B4 has told very clearly, that sentinel lymph nodes gives us the same thing, reducing the axillary dissection, and gives a complete staging workup. And it assists in optimal adjuvant systemic therapy also to plan for. So what has changed? The change that is coming is that eliminating axillary lymph node dissection in clinically N0 patients with negative sentinel lymph nodes, diminishing the use of axillary lymph node dissection in CN0 clinically node 0 patients with positive sentinel lymph nodes, and demonstrating equivalent outcomes with less morbidity, whether axillary RT versus axillary lymph node dissection in CN0 patients can be done or not, and diminishing the use of axillary lymph node in patients with subclinically or clinically involved axilla with the use of neoadjuvant chemotherapy. So these are the questions that is to be answered with the new evidence. So over the years, what has neoadjuvant chemotherapy given to us in the axilla? In the axilla, the nodal metastasis, neoadjuvant chemotherapy has given a conversion rate from node positivity to node negativity in the range of around 30 to 40%. And the trials that has given these results are NSABP 18, EOR, TCTO, and NSABP 27. Thus, potentially decreases the extent of axillary surgery with sentinel lymph nodes can be done or not. So when the conversion of axilla from node positive to node negative is around 40%, and these are the different chemotherapeutic protocols which has raised the pathological complete response rate from 7 to 8% by CMF-based regime to presently in TNBC anthracycline-based chemotherapy plus carbo plus checkmate inhibitors in the range of 60 to 65%. So this is a pathological complete response rate we find nowadays with neoadjuvant chemotherapy. What happens, when you give neoadjuvant chemotherapy, the sentinel lymph nodes and the lymphatics get scarred. And there's a hypothesis that because of the scarring of lymphatics and lymph nodes, there are new sentinel lymph nodes are there, which are non-sentinel lymph nodes. So this may give a fast FNR, that is false negative rate, more in comparison. And second, the biological phenomenon that they say is that tumor regression after neoadjuvant chemotherapy may vary in sentinel lymph node and non-sentinel lymph nodes. These two hypotheses gives that the false negative rate may increase, but it doesn't happen. So decreasing the extent of axillary surgery with neoadjuvant chemotherapy, this concept is currently being evaluated only in operable breast cancer, that is clinically T1 to T3, N0 and N1, not in cases, mind you, not in cases which are T4, clinically N2 or matted nodes and inflammatory breast cancer. So this is up till T1 to T3 and N0, N1 clinically breast cancer cases only. How best we can analyze the axilla? Ultrasound is the best modality, which is minimally invasive and can provide useful information to us about the sentinel node, the chemosensitivity of the tumor, and we can mark the lymph node for future removal by this with a sensitivity of 45 to 90% and a specificity of 100%. But mind you, here the size of the metastatic lymph node should be more than 5 millimeter to have 93% of sensitivity, which is less than 44%, which is 44% less than 5 millimeter size metastatic lymph node. So management of patient with clinically N0 axilla before neoadjuvant chemotherapy. Many years of debate, sentinel lymph node has become after neoadjuvant chemotherapy has become an arguable standard for patients with clinically N0 disease. This approach capitalizes on the downstaging effect to a neoadjuvant chemotherapy in subclinically involved axillary lymph nodes. And there are no differences in sentinel lymph node identification rate and false negative rate when compared to upfront sentinel lymph nodes. And this only meets the criteria and allows us to give neoadjuvant chemotherapy in these patients in locally advanced breast cancer. So there was a meta-analysis of sentinel lymph nodes after neoadjuvant chemotherapy in clinically N0 T3 lesions, where 16 studies were taken in consideration, and the pooled identification rate of sentinel lymph nodes after neoadjuvant chemotherapies was 96%, and false negative rate was 6%. And it was concluded by this that sentinel lymph node is technically feasible and accurate for axillary staging in initially clinically node negative breast cancer patients after neoadjuvant chemotherapy. Is it clinically important? Yes, it is, because the patients with clinically N0 who are candidates for neoadjuvant chemotherapy have a high rate of subclinical involvement of axilla, which was clearly demonstrated by NSABP 18 trial, where the surgery was done and the axilla was positive in 48% of patients. And after neoadjuvant chemotherapy, the axilla was positive in 33% of these patients. So what does it say? It says that involvement of axilla, the sentinel lymph node involvement of axillary nodes, 4 prospective studies was done where mapping of the axillary node was done by dual tracer techniques in GANIA2 and Z1071 and only by technetium by Sentina and SNFNSC trials. In these all trials, preoperative biopsy was done to know the status of the sentinel person of these patients. And the identification rate of sentinel node was between 80 to 92.7%, which was so good. And the false negative rate averagely was approximately between 8 to 12.6%. But mind you here, if the sentinel lymph nodes retrieval is more than 2 in numbers, the false negative rate dropped down to less than 9% in these series. Meta-analysis of another sentinel lymph node after neoadjuvant chemotherapy in patients with documented involvement of axillary nodes. There were 19 studies with 3,398 of the patients where the false negative rates were 13% and identification rate of sentinel lymph nodes was 91%. And the conclusion of this meta-analysis was that sentinel lymph node after neoadjuvant chemotherapy in biopsy-proven node-positive patients results in reasonably acceptable false negative rate and identification rate, making it a valid alternative to lymph node dissection. But we need to have more refined patient selection and optimal techniques to improve the FNR and identification rate in this patient population. There was re-analysis by Z107 where they put a clip inside the identified positive lymph node and they removed that they clipped the lymph node. And the results of this observation was that the false negative rate where the clip was retrieved as the sentinel in the sentinel lymph node, the false negative rate was 6.8%. Where the clip was not identified in the sentinel, it was the FNR was 19%. And but in the axillary lymph node, it was found out. But where the clip was not placed or not identified either by sentinel node or axillary dissection, the FNR was high. It was between 13 to 14.3%. There was a beautiful study by MD Anderson Cancer Center, the experience of approximately around 400 plus cases where they clipped the sentinel positive lymph node. They clipped the positive lymph node, and what they found that the clipped node was removed and gave chemotherapy to those patients. The pathological CR was in the range of 37%, and the false negative rate was 4.2% only. Where only sentinel lymph node was dissected out, the false negative rate was 10.1. When the sentinel node and the clipped node, which was positive node before surgery, which was the false negative rate was still lesser, that was 1.4%. So that gave a new hypothesis of doing a targeted axillary dissection, which means that you have to remove the sentinel lymph node as well as the pre-op positive proved axillary lymph node, which is you have clipped already, to have the false negative rate approximately less than 5%. The other methods that people have used are in Netherlands. There's a radioactive iodine substance, iodine pellet was used to mark the sentinel lymph node after neoadjuvant chemotherapy. And what they found was that the identification rate was 97% and the false negative rate was 70%, 7%, which is still proved that this is achievable, this is a doable technique now. The marked lymph node biopsy and TED, that is targeted axillary dissection, which includes clipped node dissection and sentinel lymph node dissection after neoadjuvant chemotherapy. There was systemic review which was done by Swankar et al. In 2021, which has taken in consideration of 9 studies with the marked lymph node dissection and 13 studies with targeted axillary lymph node dissection. So overall, false negative rate was 6.2% in MLNB group alone and 5.16 in TAD group, which is lesser than MLNB group. These
sorry to interrupt, sir. Sir, only 1 minute left, sir. Only 1 minute left.
Yeah, these FNRs are significantly below. So what it proves that, and the different materials are being used for it now. Stainless steel pins are used, titanium pins are used, microclips are used, polyglycolic acid are used, carbon, radioiodine, ferromagnetic, and these can be used, for that. For that optimization, now I'll just come to the conclusion that advances in neoadjuvant chemotherapy has increased the rate of sterilization of subclinically or clinically involved axillary lymph nodes. Before neoadjuvant chemotherapy, axillary ultrasound with FNA core biopsy and marking of suspicious lymph nodes should be considered. In clinically N0 patients, SLNB after NAC has similar performance characteristics as SLNB. And in patients with documented positive sentinel lymph nodes who receive NACT, the FNR of SLNB is around 13%, but it can be decreased by less than 10% if we remove 2 or more lymph nodes or use dual agents mapping and use immunohistochemistry along with that. Marking the involved axillary lymph nodes after neoadjuvant chemotherapy removal, marked lymph node decreases the FNR rates to 6 to 7%, and removal of marked lymph nodes plus the sentinel lymph nodes further decreases the false negative rate to 3.5%. Axillary recurrence rates in these studies are very minimal, less than 3% in different series. And the necessity of completion axillary dissection in N1 patients who are to be found with SLNB positive after neoadjuvant chemotherapy is currently being investigated in randomized controlled trials. Thank you very much.
Thank you,
Dr. Nitin. Thank you, Dr. Nitin, for your presentation. So now may I have the privilege to invite our star radiation oncologist, Dr. Manish Chomal, who is the Director of Radiation Oncology at SCG Cancer Center. And Dr. Chomal will be delivering his lecture on can radiation replace axillary lymph node dissection after a positive sentinel lymph node biopsy. Dr. Manish.
Good morning, everyone. I thank Dr. Somani for this wonderful meet with all the recent data of last recent breast meet, and I am now sharing my screen.
While you are sharing your screen, can I just say good morning to everybody?
Good morning, sir.
Sir, good morning.
Good morning, sir. Going ahead with the program before time.
Is my screen visible to all?
No, not yet.
Your smiling and the bright face is visible, Manish.
I think I might need the help of the IT person. So,
Dr.
Manish
Sumita
is looking divine.
Good morning, Dr. Sumita.
Yeah, good morning, boss. Nice to hear you after a long time.
I know.
But boss visible नहीं है मैडम.
He is not visible.
So
सर मिस्टर इंडिया की तरह बाहर से कमांड दे रहे.
Chalo, Dr. Chomal, all
sir,
your...
my screen is visible now or not?
Yeah, visible now.
Yes, it is visible.
Okay. So I'll begin with my talk. So the talk is going to be, can radiotherapy replace axillary lymph node dissection after positive sentinel lymph node biopsy? So again, this is based on a presentation by Dr. Reshma Jagsy from Michigan, presented in San Antonio very recently in December 21. So we start with the motivation to seek an alternative to ALND, and we all can see and appreciate this picture. So there is 12 to 30% of incidence of lymphedema after ALND in different series recorded. When we see the history of trials of axillary treatment in breast cancer, we can divide this period into certain eras. So from 1950s to 1980s, that is a pre-sentinel lymph node era, where the axilla was managed mostly by surgery or sometimes with radiation. 90 onwards to up to 10 is the time when sentinel lymph node biopsy was coming into picture in big way, and there are multiple trials. So the initial decade was revolving around lymph node biopsy, sentinel lymph node biopsy, or it should be followed by axillary dissection. So there are around 12 major trials to address this thing. From 2000 to 2010, the focus diverted in some of the trials that the address of axilla after SLNB can be either radiotherapy or dissection. So there are only 2 trials which has directly addressed this thing. And now there are even some trials which are trying to find some patient where even SLNB is not required. So the historical or pre-sentinel lymph node era, some landmine trials also if we analyze, we can see there is some comparison between surgery and radiation. So NSA-BP B04 is one of a major trial where they randomized clinically node negative to undergo radical mastectomy versus total mastectomy with regional nodal irradiation, or only total mastectomy, not addressing any regional nodes. And for node positive patients, they randomized to radical mastectomy or total mastectomy, and the regional nodes are addressed by radiation. What they found is that there is similar regional recurrence rates in both the arms. Fisher and et al. Presented 25-year follow-up of this study, and they found that the regional recurrence rate was almost around 4% in both of these arms. While they also saw that lymphedema was very less common in the patient who received auxiliary radiation. The other important thing which was found that after in the patient who had clinically negative nodes and they underwent ALND, a substantial proportion of the patient has found to be pathologically positive axilla. Now coming to the main two trials which compared direct axillary artery to ALND in this SLNB era. So these trials are AMAROS and PORTOSOL. We'll first discuss about AMAROS in brief. So this is the trial where radiotherapy or surgery of axilla after a positive sentinel lymph node biopsy was studied. It was a randomized multi-center non-inferiority trial. The recruitment was done from 2001 to 2010. 1425 patients with clinically negative axilla, but with positive sentinel lymph node biopsy were evaluated. ALND they defined as dissection of at least level 1 and 2 of axilla, and minimum nodes dissection required was at least 10 nodes. For axillary RT group, the dose given was 25 fraction of 2 gray, that is 50 gray in 25 fraction, which included axilla and SCF also. And the trial design was clinically T1, T2, N0 patient. Beforehand, they randomized that the patient either will go to ALND or axillary RT. Then on finding of sentinel lymph node biopsy, the negative patient were excluded for any axillary management, and sentinel node positive patient were, as per the randomization, went to either radiation or dissection. So this was the general scheme of the patient. They started with 4,823 patients, and they excluded the lymph node negative patient. They excluded where some of the patient where sentinel node was not identified due to some reason. So ultimately, 744 patients went into surgery and 681 for RT. The patient characteristics of AMAROS: 40% patients were premenopausal, 82% underwent BCS. So BCS mastectomy both were allowed. 95% of the patient had 1 to 2 sentinel lymph node positive. 60% patient has macrometastasis. 61% patient received chemo. 78% patient received hormone treatment. None has received any neoadjuvant treatment in this study. And they again, like NSA-BP 04, they found that ALND group, 33% of the patient has found to have additional positive nodes on the dissection. So the primary objective was to show non-inferiority of axillary RT when compared with ALND with respect to 5-year axillary recurrence in patients who had positive SLNB. So they assumed that in ALND group, it should be, the recurrence rate should be 2%, and to reach non-inferiority on statistics, they assumed that up to 4% of the recurrences can be acceptable. There were 52 events were needed to ensure a power of 80%, but this study was criticized because of two factors: that the follow-up was short, 5 to 6 years, and majority of patients were hormone positive. So the belief was that some of these patients are going to fail later. The other criticism was that very low event rates observed, which were left the study underpowered to detect non-inferiority. The results at 5 years were The axillary recurrence in ALND group was 0.43%, while with RT it was 1.19%, but it was not significant. Likewise, DFS, OS, and were also found to be non-significant between these two study arms, and lymphedema was much lesser with the patient who underwent radiation. So they concluded that comparable control can be achieved with less morbidity when we are using radiation to address axilla. At 5 years, the lymphedema rates was 23% with the dissection arm, which was 11% with the radiotherapy arm. It was strongly significant. So to overcome that, one of the caveats that the follow-up was less. So lately they have reported 10 years of update in SABCS 18. And the same results were found to hold true even after a follow-up of 10 years. So none of the parameters were significantly different in these two arms, including the axillary recurrence rate or overall survival or distant metastasis-free survival. Both were comparable. The cumulative incidence estimated of 10-year locoregional recurrence was 3.59%, which was the thought earlier that it should be somewhere around 4%, and for ALND it was for axillary RT it was 4.07, which again was statistically similar. One specific thing here is that more second primaries were observed after axillary RT as compared to ALND. So at 1 year, 3 year, 5 year, we can see the comparison of lymphedema in ALND, that is the blue block group, and the RT, that is the red block group. Another interesting thing is that there is a notion that after addressing axilla by radiation, there might be some kind of movement restriction with the long-term fibrosis effect in the muscles, but they measured the same thing, the movement of shoulder in anti-retroversion abduction at 1, 3, and 5 years, but that again found to be similar in both of the group, whether we address the axilla with surgery or with RT. The other trial, the second trial is AUTOSOR trial. The eligible patient were clinically negative axilla, tumor up to 3 centimeter in size, randomized before surgery for ALND, or the same dose radiation to the axilla. This study again has similar kind of findings that the axillary recurrence rate, the survival at 8 year, DFS, everything came out to be similar between the ALND or the axillary RT group. While the rates of lymphedema, paresthesia, swelling, arm pain, and shoulder mobility issues were higher in axillary dissection group when we compared it with the RT group. The patient who for some reason received both of the modality, almost 10% patient received ALND and RT. The patient where heavy lymph node burden was found, and that group was the group which had the increased morbidity and lymphedema of up to 31%. But rest all other things were similar between these two groups. So the summary of MROS and AUTOSOR trials are that axillary RT is a reasonable alternative to ALND for patients similar to those enrolled on these two trials after positive SLNB. So clinically node negative, and mostly these patients are 1 or 2 sentinel node positive. But the lingering questions are that do all patients like this need a directed axillary RT to all 3 levels, or super SCF field also? So this was addressed by some other trials, and whether one should include internal memory node also in the radiation. So that again was looked after with some of the other trials which address these things. So the baseline is that the kind of RT used could also play a role, that which fields actually were used in these trials and whether all these fields were required, or we can reduce the fields in RT also. Just one slide on this IBCSG 2301 study. What they have done here is they have seen that when on doing SLNB, if we found micrometastasis, so particularly on those patients where there is no macromets on SLNB, only micromets are there. So can we skip altogether the axillary lymph node dissection? So RT was not compared, but what they have seen that do the primary surgery, either VCS or mastectomy, and randomized in these patients whether axilla has to be left or axilla has to be treated. So they found that the axillary recurrence rates are very rare even in the patient where axilla was not touched. Similarly, there is another trial, Z0011 American trial. They randomized 891 patients to ALND or no ALND after BCS. And all patients had to receive RT to the breast, but not to the node. So these two trials are the trials where they are trying to select a patient profile where axilla can altogether be skipped by both of these modalities. 77% of the patient are ER positive, 60% as macromet, 96% received systemic treatment, and the follow-up was 6.3 years. So again, they found that extremely low axillary recurrence rates were there in both of the group. And ALND not necessarily required in this patient population they proposed with this study. There are again some caveats in these. So Z0011 was supposed to treat only breast and not to address any axilla, but on the detailed analysis of RT fields, they found that at least 15 to 19% patient had some kind of high tangent radiation beam, which unintentionally covered level 1 and 2 of axilla. So probably some beneficial effect came through that RT dose received by these 1 and 2 level of axilla. These are some trials which are sorry.
Sir, we are running short of time.
I'm just about to conclude. Yes. So this is not directly that, but it is defining that in adding IMN also in some of the studies has told that it helps us in improving DFS. So the final slides, can RT replace ALND after positive sentinel lymph node biopsy? So yes, for patients like those enrolled on these AMROS or OrthoSort trial, RT can be a substitute of ALND with less lymphedema in these, but we should have some cautious in mind that these are mostly patients who are ER positive. Then some some of the RT techniques were varying on the subset analysis. So caveat we already discussed, and also the caveat is this is the only group where there are multiple data which is saying that nothing can. There is an option of not doing anything for these patients as per the treatment of axilla is concerned. So the last slide is, as always, care must be individualized, but fortunately many patients can at least safely forego ALND in the modern era, even when we found a positive SLNB. Thank you.
Thank you, Manish, for informative and precise talk. The next topic is intelligent vacuum-assisted biopsy to identify breast cancer patient with pathological complete response after neoadjuvant systemic therapy for omission of breast and axillary surgery. To throw light on this topic, I invite Dr. Abhishek Parikh. Dr. Abhishek is a young, dynamic oncosurgeon at SCG Hospital, Jaipur. Over to Abhishek.
Thank you, ma'am, for your introduction, and good morning, everyone. Thank you, Dr. Somani, sir, for providing me this opportunity and to organize this wonderful talk. I'm just sharing the slides.
While Abhishek is sharing his screens, let me tell you that Abhishek has done a lot of good work at the Mahatma Gandhi Hospital before all these people joined. I've seen the charts. He's done some fantastic work in Mahatma Gandhi Hospital. So over to you, Dr. Abhishek.
Thank you so much, sir. Thank you so much, sir, for your kind words. And it's all about because of your blessings. And sir, today we are here to discuss the very very advanced and the latest technique called the intelligent vacuum assisted biopsy to identify the breast cancer with complete pathological response after neoadjuvant systemic treatment for the omission of the breast and axillary surgery. As the more studies are now coming to exclude the surgery from the breast cancer, so as a surgeon, we definitely we don't appreciate it, but yes, of course, it is good for the patients. So as although we are aware that the vacuum assisted biopsy techniques we are using since quite long and to take the accurate biopsies, and but recently by using the various multivariate these algorithms using this
Sir,
vacuum assisted biopsy.
Sir, we are not able to see your changing the slide, sir. Can you please put it on slideshow mode, sir? Yes, sir. Okay, full screen, sir. We are not able to see the full screen.
Okay, just a minute. Is it okay now?
Yes, sir. Yes, sir. Yes, sir.
Okay. So although we have vacuum assisted biopsy, we are using since quite long, but recently we have developed this intelligent vacuum assisted biopsy technique, which is basically a machine which uses the multivariate analysis and to reduce the false negative rate. And before proceed to this study, I would like to briefly discuss about the mechanism of the vacuum assisted biopsy. So in this, under the good image guidance, we put a probe for the we insert the biopsy needle very close vicinity to tumor, and then we create a vacuum close to tumor cell, and then there's a cutting edge of the blade you can see, and then we take the biopsy. So we can take the biopsy precisely without going into the surrounding normal tissues, and we can reduce the false negative rates as much as possible. So this is the photograph showing the mammotome, which is we use for the vacuum assisted biopsy, and this is the console we use for the vacuum assisted to take the vacuum assisted biopsy attached to mammotome. So what we are the various imagings we are using to assist the vacuum assisted biopsy are the ultrasonography, digital tomosynthesis, which is most commonly used these days, and it is most cost effective also. Recently, the MRI and the PET CT scan also included to assist the this vacuum assisted biopsy, but not in very commonly in use. So I just put this slide to show that this is the mammographic images showing the tumor, and with the help of this vacuum assisted biopsy devices, we can shrink the just we create the vacuum and we take the biopsy precisely from the tumor tissue. Advantage of this stereotactic vacuum biopsy is that it is a better calcification retrieval, the less few histological variations, the less false negative biopsy, and hence this is less rebiopsy rate also. So this study was recently published, very recently in the February 2022, and published in the Journal of the Clinical Oncology, and entitled as intelligent vacuum assisted biopsy to identify the breast cancer patients with pathological complete response after neoadjuvant systemic therapy for the omission of the breast and the axillary surgery. So as Dr. Nitin Khutita has also told us, and we all are aware about this fact, that the neoadjuvant systemic treatment elicited complete pathological response in 40 to 70% of the women with breast cancer. And in such patients, the breast cancer may be considered as an overtreatment because the surgery has its own side effect, especially the axillary dissection. And by using this imaging and the vacuum assisted biopsy, that accurately detected and exclude the residual disease without performing the surgery. So the aim of this study, basically aim of the study was to validate a machine. We called it intelligent vacuum assisted biopsy, using the various parameters like patient parameters, imaging, tumor, and the web variables to detect the residual cancers after the neoadjuvant systemic therapy prior to breast surgery. There are various machines, the various multivariate algorithm machines we are using these days. And these are the logistic regression with elastic net penalty, XGP boost extreme gradient boosting tree, support vector machine we called is SVM, and the neural network. In this study, they use XGB boost extreme gradient boosting tree But in other studies, they have shown that the neural network is the most accurate among these 4 multivariate algorithm machines. So in this study, they include the 318 women with clinical stage T1 to T3 with clinical N0 or N plus, HER2 positive, triple negative, or the high proliferative luminal B-like breast cancers. And external validation is also done. And outcome measures as a false negative rate compared to surgery. So these are the observations made during the studies, and we can see in this study that by using the intelligent web, by using the various variables and this machine, there's false negative rate is almost 0.0%, although it ranges from the 0 to 2.5% in various studies, but somewhere is it close to 0. Although it has a specificity is somewhere around 40%, ranging from the 20 to 65%. And negative predictive value, of course, it was very high as 100% because the false negative rates is 0%. So by using this intelligent web, we can achieve this figure of 0% false negative rate if we compare with surgery. And this is a model. This is a complex model showing the including the various variables and which we called is extreme gradient boost tree model. And it includes the various tumor parameters, patient variables, the imaging variables, and the biopsy technique variables to create a value. And the conclusion of this study was that if we select, if we do this multivariate algorithms accurately, then definitely we can detect the patient without residual cancer, and in such patients we can avoid the surgery very precisely, very accurately. So there's one other study I would like to share. It was also recently published last year only in a European Journal of the Cancer, and the aiming of the identification of the breast cancer patient with pathological complete response in the breast cancer after the neoadjuvant systemic treatment by intelligent vacuum assisted biopsy. In this study, they have included the 457 patients, and they have included all the 4 machines I have discussed earlier, and the results are extremely good. And this shows that this neural network which we use as a machine has extremely good results with almost 0% the false negative rate, with good specificity somewhere around 67%, concluding that this multivariate algorithms can accurately select the breast cancer patient without residual cancer after the neoadjuvant treatment. And in such patients, we can safely omit the surgical part. And this further help us for the future also, because by using these extremely good machinery, good algorithms, we can avoid the breast and axillary surgery for those patients where the very good results or the complete pathological response of the neoadjuvant chemotherapy is there. And that should be definitely there. More trials are required to assure the safety of these devices. Thank you.
Thank you, Abhishek, for precise and informative talk.
Can I ask a question with the permission of the chair?
Yes.
Sure.
So, Dr. Abhishek,
Yes, sir.
what do you see the feasibility of these newer data in our context, or what do you feel that when over a period of next few years, when we will be able to avoid the certain patients or subset of the patient where probably no surgery will be required based on this data?
So based on this, there's a very promising data. Although, and sir, we have seen in our clinical practice also that where the patient where the very good results or the complete resolution of the tumor after the neoadjuvant chemotherapy, sometimes after the surgery there's no residual tumor in the breast tissues. In these patients, definitely the surgery is too much for them, with the lots of mobility, especially the arm mobilities. So, sir, this is the future. If we use this, if we do right now, we are not using these vacuum assisted devices in our center, but definitely this is the future, and we can omit the surgeries in many patients, especially where early stage tumor, where we are using the neoadjuvant chemotherapy, and we are getting the very good results in such patients, and especially in the elderly patients, and where the morbid surgeries we can avoid.
The only thing that we have to see here is that the axillary response rate is lesser in
Yes, sir.
comparison to the primary tumor tuneogen chemotherapy.
Yes,
So
sir.
axilla has to be properly staged in all these cases where we want to omit breast cancer surgery.
Of course, and this is only they are the two valid studies we have seen they lying last year and this year also. So there's lot of much more data should be there before we validate this machine as a precise.
Yeah, I agree.
Yes, sir.
So can I say a few words?
Yes, sir.
Please, sir.
Yeah. So we've had a wonderful session. Everybody has done justice to the topic. And I think we wait for 5-7 years and then we'll be saying that what we were doing was really childish, trying to cluster bomb something like an ant, or trying to excavate the whole thing just for one single pin. We will have better detection techniques, whether it is image, whether it is molecular, whether it is thermal. There is a lot of exciting research going on, a lot of work going on in imaging also, in lasers also, and in thermography also for the detection of these cells. And probably the methodology of treatment would also be very, very targeted rather than doing a full axillary dissection or irradiating the whole axilla. We would definitely have more better targeted treatments available, whether like something like a photodynamic therapy or a targeted radiation, or something like we can detect by a PET scan, so something like a thyroid ablation. So it's just a matter of time that we are going to have newer and newer modalities. But yes, a lot of progress has been done and all the three speakers have done justice to the topic. Thank you.
Thank you, sir.
Can I say something? Hello, can I say
Thank you,
something?
Dr. Rajgovind. Thank you, Dr. Rajgovind, for its good comments. And thank you, Dr. Naresh and team, for giving me this opportunity to speak something on these topics. The slogan that always clear axilla in node positive patient has changed now, because after the effect of neoadjuvant chemotherapy, there's a paradigm shift in the management of axilla and trend is toward de-escalating surgery. Now it's the post-anesthetic axillary staging, which is more important than the pre-anesthetic axillary staging, because residual disease in this axilla is a strong predictor of local regional recurrence. So the post-anesthetic response in axilla determines the axillary surgery to be done in axilla after the anesthetic. To sum up, if the patient is node negative pre-anesthetic and remains node negative post-anesthetic, then sentinel lymph node biopsy is the standard of care. If patient is node positive pre-anesthetic and becomes node negative post-anesthetic, means there is no residual disease in axilla, there is pathological complete response. One can omit axillary lymph node dissection because the local regional rate recurrence is very low. But if the patient is node positive pre-anesthetic and remains node positive post-anesthetic, means patient has residual disease in the axilla, then still the standard of care is complete axillary lymph node dissection till the result of ongoing trial comes up. But in a subgroup of the patient where 1 or 2 sentinel lymph node are positive, patient has good biological behavior of the tumor, and where RT is planned as per AMAROS and AUTOSAR trials, one can avoid complete axillary lymph node dissection, but in MDT decision. But patient with 3 or more sentinel lymph node positive, still there are no clear-cut evidence to avoid or to omit axillary lymph node dissection. And for that, we'll have to wait until that complete axillary lymph node dissection will remain the standard of care. That is regarding the first. And regarding the second topic, that is, can intelligent web replace breast and axillary surgery in a patient developing complete pathological response after neoadjuvant systemic therapy? Yes, it can. As now, breast and axillary surgery in the patient with complete pathological response after neoadjuvant systemic therapy has become a diagnostic procedure to identify residual disease on final histopathological report rather than a therapeutic procedure. Such patient can be spared from breast and axillary surgery with the help of intelligent web, which is FNR rate, false negative rate, 0 to 2%. So there's a major paradigm shift in the management of breast cancer from mastectomy to breast conservative surgery and now web, intelligent web. But before implementing this intelligent web in clinical practice, many questions has to be answered. As number one, which patient might be eligible for omission of breast and axillary surgery? Which tumor stage and biological behavior of the tumor to be considered for the risk adaptive surgery? How to integrate surgical treatment of axilla? So future trials should be evaluated the risk benefit ratio for further de-escalating surgery. Over to Dr. Shantaman for radios
Thank you,
of breast.
Yeah, as rightly said by our speakers as well as our other chairpersons, the ultimate outcome, the goal of the treatment should be the optimal utilization of the whole of the three modalities of the treatment, that is radiation, surgery, as well as medical oncology part. But it should be taken with a pinch of salt so that there should be an optimal utilization, meaning by that we should not overtreat, but at the same time we should not compromise with the disease outcome. So like rightly said by Dr. Manish, that we are trying to de-escalate the axillary dissection part and just try to treat by only one modality of treatment, may it be surgery or by radiation therapy. So that is being done by NSABP 04 till this axillary mapping trials, but there has to be taken with a caveat that they should be used in a very select group of patients like T1, T2 breast or axillary lymph node not more than 1 to 2, as rightly mentioned by Dr. Sumita Jain ma'am, and with no extra capsular extension, and in only those settings in which the patients are willing to take total treatment in the terms of radiation therapy to the breast as well as cytotoxic therapies or plus minus endocrine therapies. So yes, axillary dissection can be replaced by radiation, but in a very select group of patients. Thank you so much.
So on Sunday lighter mode, Dr. Shantanu, would you like to tell us where are you traveling?
Sir, I am in Central Park.
Oh.
Just waiting for my walk.
Oh, thank you.
Okay, sir. Thank you so much.
Thank you all the chairpersons and speakers for this wonderful session. Moving on to the next session, I would like to call the chairpersons, Dr. Umesh Khandelwal sir, who is a consultant medical oncologist at Satbhogba Durlabji Memorial Hospital, Jaipur, and Dr. Hemant Adit sir, who is a senior medical oncologist at Sudha Hospital and Medical Research Center, Kota. Over to Umesh sir and Hemant sir.
Yeah, good morning, everybody. Next session, I will invite Dr. Sandeep Jasuja. He is a medical superintendent, State Cancer Institute, and head of Department Medical Oncology, SMS Medical College. He will talk about trastuzumab deruxtecan versus trastuzumab entamacin in metastatic breast cancer patient, those who are HER positive, subgroup analysis from randomized phase 3 Destiny Breast 3 trial. Over to Dr. Sandeep.
So, sir, Dr. Sandeep is not able to make it. So, Dr. Mukesh Surania is doing the needful. So, Dr. Mukesh, all over to you.
Yeah.
Yes. So, my this topic is trastuzumab deruxtecan versus trastuzumab emtansine in patients with HER2 positive metastatic breast cancer in second line setting, with subgroup analysis from the randomized phase 3 study Destiny Breast 03. So this study is recently presented in SABCS December 7 to 10 21, and this is first randomized phase 3 study of trastuzumab deruxtecan open label multicenter study, which compared trastuzumab deruxtecan versus TDM1 in HER2 positive breast cancer after progression on HER2 directed therapy, and they compare unresectable or metastatic HER2 positive breast cancer that has been previously treated with trastuzumab and a taxane based chemotherapy, could have clinically stable and treated brain metastasis, and should have more than or equal to 2 weeks between end of WBRT and the state enrollment. And they analyze the primary endpoint is PFS and key secondary endpoint is overall survival. And these are baseline characteristics between the two groups, and these are well balanced. So primary endpoint is progression-free survival, that is analyzed by blinded independent central review, and they compared trastuzumab deruxtecan versus TDM1, and they showed that 1 year PFS is higher with trastuzumab deruxtecan as compared to TDM1, and median PFS is not reached with trastuzumab deruxtecan as compared to only 6.8 months with TDM1. According to subgroups, and this forest plot showing that in all subgroup of patients, trastuzumab deruxtecan have higher PFS as compared to TDM1, and like there is a hormone receptor positive or hormone receptor negative, prior pertuzumab treatment or without prior pertuzumab treatment, visceral crisis or without visceral crisis, irrespective of prior line therapy, and patients with brain metastasis or without brain metastasis. All patients in TDXD arms have greater PFS benefit as compared to TDM1. So confirmed overall response rate across patient subgroups, as we know, that showing that overall response is higher in TDXD arm as compared to TDM1 arm. And this is Kaplan-Meier curve PFS for patients with and without brain metastasis. If patients have brain metastasis at baseline, then median PFS with trastuzumab deruxtecan is 15 months as compared to 3 months with trastuzumab emtansine. And 1 year PFS rate is 72% with trastuzumab deruxtecan as compared to only 21 months with TDM1. And if patients have no brain metastasis at baseline, then median PFS is not estimatable with trastuzumab deruxtecan, and 1 year PFS is 77% as compared to only 36 months with TDM1. So this table showing that confirmed overall response and the best overall response in TDXD versus TDM1, and they show that complete response rate is higher with TDXD, partial response is higher with trastuzumab deruxtecan, stable disease also comparable with TDM1, progressive disease is more with TDM1. So intracranial response rate per blinded independent central using RECIST 1.1 criteria, and we show that TDXD have higher complete response, higher partial response, higher stable disease. As coming on overall and exposure adjusted safety summary, this table shows that treatment emergent adverse events of grade 3 or more is higher with trastuzumab deruxtecan, that is comparable with TDM1, and serious events is also almost similar to TDM1. TEAE associated with discontinuation is more with trastuzumab deruxtecan as compared to TDM1, and TEAE associated with dose reduction is almost similar to the TDM1. So treatment emergent adverse events in more than or equal to 20% of patients, we show that neutropenia is higher with trastuzumab deruxtecan, anemia is also higher with trastuzumab deruxtecan, thrombocytopenia is more common with TDM1, nausea vomiting is also very common with trastuzumab deruxtecan, constipation is also common with trastuzumab deruxtecan, and special side effects which we concerned with trastuzumab deruxtecan is interstitial lung disease or pneumonitis, which is only mainly in grade 1 and grade 2 range. No grade 4 and grade 5 adverse events of interstitial lung disease was observed with trastuzumab deruxtecan. So this can be safely incorporated as a very low level of grade 1 and grade 2 side effects can be incorporated with and compared with TDM1. And ILD and pneumonitis rates were similar between the overall population and the Asia subgroup, and between the Asia and the non-Asia subgroups. So from this study, we can conclude that trastuzumab deruxtecan treatment demonstrated consistent efficacy benefits, PFS, and overall response rate over TDM1 across all patient subgroups. PFS for trastuzumab deruxtecan is 0.28 overall. Confirmed overall response rate for trastuzumab deruxtecan is 80% versus only 35% with TDM1. In patients with or without brain metastasis, trastuzumab deruxtecan treatment resulted in greater efficacy compared to TDM1. Patients with brain metastasis, median PFS of 15 months with TDXD versus 3 months with only TDM1. Confirmed overall response rate of 67% with TDXD versus only 20% with TDM1 in brain metastasis. Low rate of progressive disease with trastuzumab deruxtecan 32% versus 60% with TDM1 for patients with brain metastasis, and 49% with TDXD versus 70% with TDM1. TDXD treatment is associated with substantial intracranial response and reduction in CNS disease. 28% intracranial response rate for TDXD versus only 2.8% for TDM1, and 2.8% intracranial progressive disease for TDXD versus 23% for TDM1. So TDXD demonstrated a manageable and tolerable safety profile in all subgroups with no difference between Asia and non-Asia regions in ILD and pneumonitis rate, with no grade 4 or 5 ILD pneumonitis events. So from these data, we support TDXD becoming the standard of care for second-line HER2-positive metastatic breast cancer. Thank you.
Thank you, Dr. Mukesh, for comprehensive discussion about this trial. For second talk, I will invite Dr. Uttam Soni. He is a consultant oncoplastic breast surgeon, Sita Devi Hospital, Jaipur. He will deliver talk about oligometastatic disease, definition and practice pattern in breast cancer. Over to Dr. Uttam Soni. You have to unmute it.
Unmute it. I'm okay. Am I audio? Am I audible now?
Yes, yes, yes.
So thank you so very much, Hemant boss.
Yeah.
Nice to see you early in the morning on a Sunday.
Yeah.
Am I supposed to share from my screen, or the talk is going to come from your side?
Please share your slides.
I share it from my. Okay, so I'm sharing the screen. Okay. So good morning, everyone. Thank you so very much. And many thanks to Naresh Somani boss for giving me an opportunity to interact with an august audience, which is present today here. I've been given a task to talk about oligometastatic disease, definitions and practice patterns. Now, essentially, this is a paper that was presented in SABC, and that is quite relevant to today's world also, because I think most of the times in most of the centers, whenever you think of metastatic disease, you just think of stage 4, and the patient relatives, including some people in the medical team, also thinks of that this is end of life program. But now with a differentiation of metastatic disease into oligo and systemic metastatic disease, we have been able to do more justice to these patients who have metastasis to different organs, but they are limited and they are treatable. So what the definition of oligometastatic disease says. So oligo comes from, it's a Greek word which means scanty or few. And at the end of this talk, I think probably we'll be able to make out what oligometastatic disease is and what should be the practice patterns and what is going on new in the world. Now, this is a combined venture with Estro and EORTC. So let's see what is there in the bag. I have no conflicts of interest except knowing Dr. Naresh Somani personally. So what is the concept of oligometastatic disease? We have localized disease, which we can cure with local treatment. Oligometastatic disease is a disease which has actually moved on from the primary site to different other sites, but these are fewer in numbers. And they are, the cure is possible with local treatment. And then we come to systemic disease, wherein we just focus on more of improving quality of life rather than treating the disease. So the intent changes from cure to palliation. Growing evidence of metastasis of directed radiotherapy. Now, this is something which has been going on. So this has been going on from 1995, and you can see that from 2010 onwards, there's been gross increase in the number of trials or number of work that has been done on providing radiotherapy to the metastatic sites. And plenty of them have been done, and the numbers are increasing. We've been able to do retrospective, prospective, phase 1, phase 2 trials also. But there's no level 1 evidence still available on metastasis-directed radiotherapy. So radiotherapy as a modality to manage oligomets, we still don't have level 1 evidence. The work is still going on. There are a lot of studies which have been done, like the one by Anger on Inzama, Gomez, NJCO, Wang, NASCO, Palma, NJCO. So there's plenty of them, but there's several randomized controlled phase 2 trials. They all report a significant and clinically relevant benefit of multidisciplinary treatment of these metastatic disease. A very important thing is continuously changing multidisciplinary treatment. So surgery is changing, radiation is changing, medical oncology systemic treatment is changing. We are having more of targeted therapies now. Imaging modalities are changing. Patient population is changing. Obviously, there have been a change in generalized makeup of patients that we are getting. In India, if we talk about, and particularly breast cancer, we're getting more of triple negatives and younger patient group as compared to the Western world. And changing in disease presentation also. Breast cancer that was a disease of elderly population is now becoming more and more prominent in the younger generation. So, you know, everything is changing, and so we need to change the treatment plans also. We need to change the approach also to these diseases. Now, if we talk of oligometastasis disease or metastatic disease, it is more of an imaging diagnosis. So we don't have validated molecular biomarkers for this disease. It is currently just a diagnosis of imaging. And we have 2 good papers. One is this in EJC, which says strategies and technical challenges for imaging oligometastatic disease. There are recommendations from EORTC group, and use of modern imaging methods. Again, it's from EORTC. So more of OMD, more of an image defined diagnosis. Now, what are the imaging guidelines? For breast, new primary and recurrent disease, there have been guidelines from ESMO and NCCN as well. All of them, they say that we have to be very judicious in using the modalities. And whenever we use an advanced modality like PET-CT, it has to be justified clearly. Cesium and PEST. Do you know what it is? Do you know what it is? So this is a treasury of images, very famous French painting by René Magritte, 1927-28. Now this is a French saying which says that this is a cigar. Do you see? This is a cigar. So this is not a cigar. This is not a pipe. This is picture of a pipe. So same as with oligometastatic disease, it is not a metastatic disease. It is still curable with local treatment. So we have to take it this way. Characterization and classification of oligometastatic disease. Again, an EORTC recommendation brought up in Lancet Oncology in 2020. It was to develop a consensus nomenclature and comprehensive system for oligometastatic disease characterization and classification. Now, they put 5 key questions in it there, and they divided or classified OMD into 9 different states, and these were de novo. Again, de novo oligometastatic disease, that was at the time of diagnosis, whether it is synchronous or metachronous. Is it repeat oligometastatic disease? Patient having a previous history of oligometastatic disease. Is it induced, so that patient has previously history of polymetastatic disease? Oligorecurrence, wherein the patient has been free with systemic therapy, it has come back. Oligoprogression, the progression is under systemic therapy. Patient is undergoing systemic therapy and disease has progressed. And oligopersistence, so the disease have not progressed, but still there. So these were the classifications that were done And then they did make a dynamic oligometastatic states model also. This validation was done by Zurich University Experience. They classified again into de novo OMD, repeat OMD, and induced OMD. And we can see that the number of de novo OMD was like, plenty. 389 patients, they were treated, and they were treated for maximum 5 metastases. So this is one sort of cutoff line wherein we take that patients having distant metastases which are completely treatable, but they should be less than 5 in number, and they're taken as OMDs.
Sorry to interrupt you, sir. Only 2 minutes left, sir.
Only 2 minutes, so I have to go. I have to go very fast. URTC Astro radiotherapy infrastructure. So this was E2 Radiate, which was a program by Astro and URTC in collaboration with each other. They did work on it. The goal was to bring real life data of cancer patients who were treated with radiotherapy, provide evidence of the role of radiotherapy in a multidisciplinary approach, support the radiotherapy research, and generate hypotheses for future clinical trials. And there were 3 cohorts, which are oligocare, particle care, and recare. They have minimum inclusion criteria. And for each cohort, we had endpoints which were disease-free survival, local regional control, distant metastasis-free survival, overall survival, and so on. Oligocare was a report which came in after a collaboration from URTC and Astro. It was a pragmatic observation cohort study to evaluate radical radiotherapy for oligometastatic cancer patients. Objective was to identify patient, tumor, diagnostic, and treatment characteristics influencing safety and efficacy. The primary disease could be in lung, breast, prostate, and colorectal region. There was no upper limit of number of metastases as long as all are treated with radical intent and at least one with radiotherapy. So the intent was to treat, was to cure. And it was a lively research collaboration. There were 868 patients enrolled as of 20th September. And there are 5 hospitals. They're recruiting it very actively. The initial results have been very encouraging. The Convention for Innovative Radiotherapy Belgium. So Belgian Cancer Registry has been working on it. And patterns of care, they are working on SBRT, but there's no reimbursement. Registration of innovative radiotherapy, they are collecting indications and technical characteristics to map the diffusion and to monitor the safety and effectiveness. It's planned for 4-year period time, 213 to 216, and it extended to 217 before analysis. SBRT indications are there. Initial analysis, data collection says that we have 6296 SBRT registrations. Collection of patient characteristics, age, gender, WHO characteristics, tumor characteristics, treatment characteristics, and outcome survival. How is the patient surviving? 2790 SBRT cases of oligometastatic disease. Most frequent primary tumors were in colorectal, prostate, lung, breast, and kidney. And you can see that breast is doing really fine with SBRT. Patterns of care in United Kingdom, I think we don't have time for this, but survival, local control, and toxicity, they're good. So results are very, very good. Adverse events, grade 3 fatigue, grade 4 increased liver enzymes are there, but there's no grade 5 side effect with regards to SBRT. We have some very good real world evidence on SBRT for oligometastatic disease. And these are definitions for oligometastatic disease: synchronous, metachronous, oligoprogression. And we just talked about this Astro consensus, which is important. It's supported that OMD is independent of primary tumor, metastatic location, and presence or length of DF interval. Both synchronous and metachronous systemic therapy-induced OMD is a distinct state of OMD. The ability to deliver safe and clinically meaningful radiotherapy with curative intent to all metastatic sites is a minimum requirement for defining OMD in the context of radiotherapy. So all the metastatic sites should be accessible to radiotherapy, and the intent should be curative. High resolution images to assess and confirm OMD is crucial, including brain imaging when indicated. Now, it can to debate be classified as 1 to 5 metastatic. A controlled primary tumor being optional, but where all metastatic sites must be safely treatable. So this is, as I told you in the end of this talk, you'll be able to make out a justifiable definition of oligometastatic disease it can be defined as 1 to 5 metastatic lesions wherein a controlled primary tumor is there. But all metastatic sites should be safely treatable and the intent should be curative. Thank you.
Thank you, Dr. Uttam Soni, for excellent presentation. I think in chat box, Dr. Hemant Malhotra sir rightly said, now conjugated drugs are practice changing things. If we see the first trial that was Dr. Mukesh has presented, this is the first randomized phase 3 trial in metastatic breast cancer. TDXD demonstrated highly clinically meaningful, statistically significant improvement in the progression-free survival. Comparing with TDM1 in patient of HER2-positive metastatic breast cancer patients, and this benefit consistently seen in all subgroups and efficacy endpoint, with confirmed overall response rate for TDXD was 79%, comparing 34% for TDM1. And this trial also shows that encouraging overall survival trend also at the time of the first interim analysis. And if we see the safety profile, comparable in both arms, and similar rates of all grade and grade and more grade 3 drug-related, treatment-related adverse events. And I think this study will lead to paradigm shift in treatment of HER2-positive metastatic breast cancer. Definitely, we need more data or future analysis of this trial. Second topic, which was presented by Dr. Uttam Soni, it is metastatic breast cancer. Traditionally, we have considered it incurable. With treatment, we have focused on the systemic therapy or palliative treatment goals. However, evidence are now emerging that some patients with oligometastatic disease, we often define as the 5 or fewer metastatic at the time of diagnosis on imaging. If we give aggressive metastatic directed therapy, either with surgery or hypofractionated image-guided radiotherapy or CyberKnife, may improve outcome, or even some patients we can also cure. And this practice becoming more common as evidence has grown that the support of approach as well as technology nowadays available, that made it feasible. Thank you.
So just to end it up, I must say that we are working on the same principle, and we as a unit have liaised with Dr. Manish Chaumal. I think hopefully he's around, and we have been working on this for last 1 year, and we have some very good results. Not 1 year, I think 3 years around now, and we have for last
almost 4 years, I guess.
Almost 4 years. Okay, so and these patients are doing wonderful. They are absolutely disease free. I think the intent should be straight away very aggressive, and it should be curative intent when we are dealing with these patients. Thank you so very much. That's it.
Thank you.
Thank you, sir. Divesh Goyal sir is having a question. He's raised the hand. Dr. Divesh sir. Okay, very well. So thank you all the chairperson and speaker for this session. Moving on to the next session, which is a panel discussion on immunotherapy in the metastatic setting, chemotherapy backbone and the biomarkers. So to moderate the session, I would like to invite Dr. Hemant Malhotra sir, who requires no introduction. Is a director of oncology services at Sri Ram Cancer Center and Mahatma Gandhi Medical College and Hospital, Jaipur. I would like to call the panelist, Dr. Mukul Goyal sir, who is a director and consultant medical oncologist at Asian Cancer Hospital, Jaipur. Dr. Aditi Mittal, consultant medical oncologist at Lok Bahadur Durlabji Memorial Hospital, Jaipur. Dr. Rohit Rubello, consultant medical oncologist at Ananta Hospital, Jaipur. Dr. Rohit Swami sir, who is a consultant medical oncologist at Narayana Multispecialty Hospital, Jaipur, and Dr. Devesh Goyal sir, who is a senior consultant medical oncologist at Fortis Hospital, Jaipur. Over to Hemant Malhotra sir.
Thank you, Ankit. Am I audible and visual?
Yes, sir. Yes, sir. Yes, sir. Visible and audible.
I'll share my screen. So tell me, is my screen visible to everybody?
Yes, sir. Yes, sir.
Oh, wonderful. Yeah. So let me start, and let me, first inform all the listeners, the delegates,
that we're going to talk about immunotherapy in breast cancer in the metastatic setting. And my very sincere thanks to the convener of this wonderful webinar, my very dear friend, Dr. Somani, the convener, Dr. Jitender, and the two very learned organizing chairpersons, Dr. Sumita and Dr. Bhati, like friends of more than 3 decades. And my panelists have already been introduced to you, Dr. Mukul, Dr. Aditi, Dr. Rohit, and Divesh. So let me start if my panelists are ready. First of all, I'd like to wish Dr. Mukul Goyal a very belated happy birthday. Yesterday was his birthday, so all good wishes to you, Dr. Mukul. So this is my case for you. A 52-year-old metastatic triple-negative breast cancer patient who has PD-L1 positive disease. Initially diagnosed in October 2018, left-sided triple-negative breast cancer. Standard surgery was a neoadjuvant dose-dense 3-drug chemotherapy was given. Patient had an excellent response, but did not have a complete response. She had a mastectomy, supraclavicular lymph node dissection, and because she did not have a complete response, as is now standard in TNBCs, patients who do not have a pathological CR, they are given adjuvant capecitabine, and she was given 6 cycles of adjuvant capecitabine. She didn't tolerate anymore. Now she's come a couple of months from today with left-sided chest pain. On imaging, she's found to have recurrent disease in 3 areas in the left chest, including 2 chest wall nodules, 1 rib lesion, and bilateral pulmonary metastasis. So I'm not, wasting time on this case very much. We'll rather use the time for discussion. So my first question to Dr. Mukul is, Mukul, how would you proceed? What further investigations would you want to do in this patient? Leave alone the routine investigations, CBC, biochemistry, ECG, EPO, chest X-ray, all those have been done. What specific investigations in addition do you want now? Are you on board, Dr. Mukul? Has Dr. Mukul joined? Can the organizers tell me, please?
No, sir, I have not.
Okay, so I'll go down the list. The question is to you, Dr. Divesh. Divesh, what would you do now?
Sir, as this case is the triple negative metastatic breast cancer, and now there is a recurrence. So the further my target to repeat the biopsy from the chest nodules, and will do for this the BRCA as well as the second thing PD-L1 and tumor mutation burden for to plan further treatment indication to plan further treatment.
Excellent. Dr. Aditi, can you tell me, would you like to repeat the ER, PR, and HER2 in this patient at the metastasis? Earlier she was triple negative, but would you want to repeat these 3 basic tests which we do in all our breast cancer patients?
Good afternoon, sir. So, if she recurred just after 2 months of the therapy, I would not like to go for a repeat biopsy, because most probably it was going to be, if it would have recurred up very later, then I would have gone for repeat biopsy. Or if we need tissue for the NGS or any other further tissues. Sir, yes, there is some discordance for TNBC that they change the metastatic sites can have different ER/PR status. But the natural history of the patient suggests that it is TNBC rather than any hormone positive disease. So maybe.
So my question again, direct question, Aditi, yes, no. Would you like to do ER/PR HER2 again or no?
Okay, sir, I would go with it. I will do it again just for reconfirmation.
I think then I would also it should go that because of a change in the marker or error in the initial report, and it's such a simple test to do today. In addition to what Divesh has said, you must do a BRCA1, BRCA2 mutation in this patient, and you must do PD-L1 expression in this patient. You must also do the ER/PR and HER2. Agreed?
Yes, sir. We can also do AR nowadays.
Right. So this is the ESMO guidelines with regards to the diagnostic workup and staging in metastatic breast cancer. And if you talk about TNBC patients, a PD-L1 by IHC should be done, and a germline BRCA mutation should also be looked at. Data for
looking at PALB2 mutation is grade 2A, it may or may not be done. Other markers like Aditi has mentioned, androgen receptors, they're not standard of care as of just now. So now my next question is to Dr. Ribello. We have two Rohits, so you will permit me to call you by your surname and not call you Rohit. Dr. Ribello, what assay would you use to assess the PD-L1 expression, and are there any differences, and why would you do that?
Actually, the strongest data in immunotherapy in metastatic breast cancer is for atezolizumab, the IMpassion 130 and the IMpassion 131. I think they've used the SP142 platform there. So I would prefer using that because the data there tends to be this phase 3 data, which is the strongest, and that in that reason I would prefer to use the companion diagnostic of atezolizumab.
So excellent. So, that confusion which we have in lung cancer, it, persists with PD-L1 testing in breast cancer also. And it depends on what you have in mind, what treatment are you a fan of, or which company you are a fan of, you can, choose that. But if you're planning to use Atezo, if you're planning to use number one, the checkpoint inhibitor, and if you're planning to use Atezo, then you would ask your pathologist to use the Ventana SP142 platform. And if you are a fan of Pembro and you're wanting to use the CPS more than 10 cutoff, then the preferred modality of PD-L1 testing is the DACO-22 C3 antibody. My question to Dr. Swami is, Dr. Swami, when you send the block to the pathology lab of your choice, do you ask for the Ventana or the DACO, or you just leave it to the lab to do? Is it your standard practice to inform the lab that you plan to use Atezo or you plan to use Pembro?
So in TNBC, definitely I ask whether they are going to do it on DACO or Ventana SP. And my preference between two is to go for DACO and to assess CPS score, and then to plan pembrolizumab with chemotherapy in these patients.
Okay, so I think we need to keep this in mind. At least, my practice is to leave it to the lab, which is probably not correct. You need to be clear in your mind, number one, whether your patient is a candidate for immune checkpoint inhibitors, and number two, which of the checkpoint inhibitors you have in mind. If you plan to use Atezo, then you have a different way of testing for PD-L1. And if you're planning or a fan of Pembro for whatever reason, then you have to have a different platform in mind. I don't know how many of our practicing oncologists do that, but we need to keep that in mind. And this is the, the CPS, the TPS, and the immune cell score. In the CPS, you look at the PD-L1 staining tumors and the lymphocytes and macrophages, the immune cells. In the tumor proportionate score, you look at only PD-L1 staining in the tumor cells. And in the IC score, which we use for Atezo, the immune score, you look at PD-L1 staining in lymphocytes and macrophages. So I really truly believe and feel that I wish our pathologists and our molecular pathologists can sort this confusion out and give us one test across the board for all tumors and across the board for all checkpoint inhibitors. But I don't think that is going to happen. But that is a dream which at least I have to reduce the confusion in testing. So is Dr. Mukul on board just now? Should I direct any questions to Dr. Mukul? Organizers, will you please tell me?
Still no, sir. I'm not able to see.
Okay, Divesh, do you agree with my wish that there should be uniformity in PD-L1 scoring?
So yes, I am agree with you, but sir, there is in various trials different testing was done along their molecules. So in future it may happen for uniformity, if we can discuss with this molecular pathologist. Otherwise, if we are using atezolizumab, then we will go on this Ventana, and otherwise we will planning for Pembro, then we will go on this DACO. But otherwise uniformity is required.
Yeah, I also really truly believe that I wish the clinicians could sit down with the molecular pathologist and also the checkpoint inhibitor pharmaceutical industry and sort this confusion out. So to carry on, may I ask now Dr. Aditi? Aditi, how would you treat this patient? This is a patient who is maybe a relative of the Ambanis or the Adanis, whoever you like. Expenses no consideration. How would you treat this patient now?
So, sir, of course, the finance consideration is not there. Sir, with all due respect, I would like to say that as atezolizumab was withdrawn from the market after August 2021, so I would rather go with the pembrolizumab and with nab-paclitaxel. That would be my, so that I'm not, I don't want to give steroid to the patient. So I would go with nab-paclitaxel with the pembrolizumab, and thus we can go ahead and see for the response that patient can have. If the patient is not affordable for immunotherapy, then we have our standard chemotherapy back that we have.
Our brief today is to talk about immune checkpoint inhibitors.
Yes, sir. So I would go with pembro with the nab-paclitaxel. That would be my choice.
Okay, so I may want to correct you that atezolizumab is approved by the DCGI of our country for use in triple-negative breast cancer. So that remains an option. My question to Dr. Ribello, I mean, this is a very, very important question. So can you address this for us again? Aditi has very categorically told her choice of going forward. What would be your choice, Dr. Ribello? How would you treat this patient?
Actually, that's because the IM Passion 130 data came out, and I think they'd used paclitaxel there and used steroids there. And, the control arm actually had a very significantly better overall survival as compared to the treatment arm, which is not generally seen in most other studies. So there were probably issues between the fact that, they had given steroids, and that is why in 130 you found a more inferior result. But 131 actually had a good result with nab-paclitaxel. So I don't think there is so much of a difference between the two. Although the company actually has withdrawn it last year as an indication for breast cancer. But I don't think there is a significant difference. But and if it's approved by the DCGI, then I think ATI or Pembro is just a matter of personal choice and experience. And considering 131 had good results, it was a phase 3 randomized study. I think there's a small problem, sir, with the previous discussion on PD-L1. I think I think gene expression profiling, tumor and tumor infiltrating lymphocytes. I think in breast cancer, that I think plays a more important role rather than just looking at it as triple-negative breast cancer. I think that is why we are not finding the exact patient to give, because we're taking triple-negative as one whole subset. And I think more needs to be done to identify a subgroup of triple-negative that's probably more responsive to immunotherapies.
So excellent, but I think you're still sitting on the fence, Dr. Ribello. Like, would you use atezolizumab in this patient along with chemo, whatever chemo you decide, or would you use Pembro?
I would use ATI because I'm more comfortable with ATI because I've used ATI quite a bit. So
wonderful. So we have one panelist opting for one checkpoint inhibitor and one panelist opting for the other, which is how it should be. It should be fair and free. So this is again the ESMO. I actually prefer the ESMO to the NCCN because European practice is a little more in sync with Indian practice. So for patients who have triple-negative metastatic breast cancer and who express the PD-L1, you have a choice of using atezo with nab-pacli, or you have a choice of using Pembro with a whole bunch of chemo regimes, which we'll discuss subsequently. And both these agents are approved in our country. You may want to know that atezo is approved in the European Union, while it is not approved by the US FDA, and Pembro is approved in the US and not approved in Europe. So again, depending upon which part of the world you practice. I mean, we are lucky in India that we have a choice of both the agents. Some little bit of theory and review of the studies which the panelists have been quoting. Usually checkpoint inhibitors have lagged behind in breast cancer as compared to several other cancers. But this story is now changing with triple-negative breast cancer, because this particular group of breast cancers, the TNBCs, they have higher tumor infiltrating lymphocytes as compared to the estrogen receptor or the HER2 receptor positive patients. They have a higher expression of PD-L1, and they also have more non-synchronous mutations. And these are the reasons why checkpoint inhibitors are making a little bit of comeback in triple negative breast cancers. And just a quick review of the clinical trials which Dr. Ribello was talking about. This is the IMpassion 130 trial, randomized double-blind placebo-controlled phase 3 study. Patients with metastatic or inoperable locally advanced TNBC. No prior therapy in the advanced setting, but prior RT and chemo in the curative setting is allowed, provided the disease-free interval is more than 12 months. And they, had to have measurable disease and good performance status. Atezo plus nab-pacli, standard doses versus placebo plus nab-pacli 1-to-1 randomization. Primary endpoints PFS and OS. And this is the intention to treat population. All the patients bunched together, hazard ratio of 0.8, p-value of 0.002. And if you tease out the PD-L1 population, then you have a much better, much more significant hazard ratio with atezo plus nab-pacli 0.63, delta of 27, and a p-value of less than 0.001, which is highly significant. And this is the basis of which the approval was given to the study. Overall survival analysis, again, at 3 years, 22% in the chemo alone arm versus 36% in the checkpoint inhibitor plus chemo. And this hazard ratio is 0.67. Confidence intervals are reasonably narrow. So this is an important result. The IMpassion 131 study, quite similar inclusion criteria, and less impressive results in the PD-L1 population, hazard ratio of 0.82. And this is the other checkpoint inhibitor, pembrolizumab, Keynote 119. And you can see that in the whole population, the hazard ratio was not significant. But if you tease out the patient who have CPS of more than 10, then the hazard ratio is 0.78. And if you pick up a subset of patients with even higher CPS, more than 20, then the hazard ratio does get better, 0.58. And this is the, the randomized study with Pembro, the Keynote 355. This was a 2:1 randomization, Pembro plus chemo versus placebo plus chemo. And these were the chemos which were used, nab-pacli, pacli, and gem-carbo. And here are the results for you. This is the intention to treat population curve, Pembro CT plus placebo CT, PFS 5.6 versus 7.5, hazard ratio 0.2. And now if you choose the patients with PD-L1 CPS equal to or more than 10, then much more impressive results. Median PFS of 5.6 in the placebo plus chemo as compared to the Pembro plus chemo 9.7, hazard ratio of 0.65, and a very significant p-value. And this is the forest plot of the subgroup analysis. And you can see that patients who had prior neoadjuvant adjuvant chemotherapy versus patients who were chemo naive, the chemo naive patients did a little better. Patients who had de novo metastatic disease did a little better. The hazard ratio was 0.48. And the patients, if you look at the metastatic sites, patients who had more metastatic sites, they again did a little better. So if you have a patient who has not received any neoadjuvant adjuvant chemotherapy, or if who has received these therapies, but the disease-free interval is more than 12 months and there are lots of metastasis, then possibly there is a bigger role and a better hazard ratio of combining a checkpoint inhibitor in these patients. Now, what about the chemo backbone? There is pretty clear evidence as per this forest plot that if you use the taxane, it is better than gem-carbo. whether you use nab-pacli or pacli. In patients who have CPS more than 10, the pacli is as good or maybe a shade better than nab-pacli. Hazard ratio is 0.3 here, 0.7 here. So possibly the best combination for the high-risk patient would be a combination of pacli plus pembro. So now my question to Dr. Swami now. Dr. Swami, are you convinced that there is a role of immune checkpoint inhibitors in metastatic breast cancer, TNBC or non-TNBC?
Definitely, sir. In TNBC, there is definite role of immunotherapy.
For all patients of breast cancer or only different?
So for TNBC, in HER2 positive, if MSI is if unstable MSI, or if PD-L1 is more, then we can go for immunotherapy. But in TNBC, definitely there is a clear.
What about the patient of TNBC who does not have a high PD-L1?
So, sir, if PD-L1 is more than 1 only, and so we can go with the nab-paclitaxel and atezolizumab. If PD-L1 is more than 1 and CPS is more than 10, then we can go with pembrolizumab and chemotherapy.
Right. Okay. Thank you very much. So, like just a snapshot that immune checkpoint inhibitors are being used in the neoadjuvant setting also. You have the GPARC NUMOS trial in which durvalumab was used. This was used only in the neoadjuvant setting, no adjuvant, not in the adjuvant setting, and a delta of 9.2 in favor of nab-pacli plus druva. Then the NeoTrip study in which nab-pacli carbo was used with or without atezolizumab, again, not used in the adjuvant setting, a delta of 2.7. The Keynote 522 in which pacli carbo with or without pembro. Here, pembro was used for 1 year in the adjuvant setting also, and the delta over here is 13.6. Then the IMpassion 031, nab-pacli followed by AC with or without atezolizumab, again given in the adjuvant setting also, and a delta of 16.5. So neoadjuvant immune checkpoint inhibitors continuing into the adjuvant setting or not continuing into adjuvant setting, there is a little bit of benefit. I mean, it's for you to decide whether this is adequate or not. So this is my last slide before I wind up. So responses to immune checkpoint inhibitors in metastatic TNBC are moderate. Factors which determine your choice whether you use these expensive drugs is line of treatment, PD-L1 expression, and still under study are tumor infiltrating lymphocytes and tumor mutational burden. Atezo nab-pacli is approved for first-line treatment in PD-L1 positive advanced TNBC as per IMpassion 130. No added efficacy with paclitaxel backbone as per IMpassion 131. The PD-L1 expression has to be more than 1% as per Ventana SP142 assay. And similarly, pembro plus nab-pacli or pacli or gem-carbo is approved for first line in PD-L1 advanced TNBCs. The PD-L1 combined score has to be more than 10, and this has to be assessed in the DACO22C3 platform. So this is my last slide. I'd like very quick 15-second comments from each of my panelists. Like, do they use checkpoint inhibitors? And which one do they use in the triple negative setting in which PD-L1 is expressed, starting with Dr. Devesh.
Sir, again, still my experience is nil in the breast cancer with this immunotherapy. But if the patient is affording, and then I can use the AT versus pembro, but I am fan of AT compared to the pembro.
Agreed. So he would use in PD-L1 positive patients, and his choice is AT. Yeah. Dr. Aditi.
Sir, I think I need more. I need to find a subset of patients who would actually respond to immunotherapy. So I would still go with not go with the immunotherapy. Rather, if it is the last resort, and I would go with the simple chemotherapy for now. Wonderful. And would then take chance.
Wonderful. You are in the same side of the treatment group as I am. Dr. Rubello.
I agree with Dr. Aditi. I am not really convinced about the data yet. I'm waiting for some more to put my patient on such expensive therapy.
Wonderful. So like we have a very conservative and a very cost conscious panel. I'm very, very happy about that. Dr. Swami. Dr. Rohit Swami, are you there?
Can I ask a question?
Yes, please go ahead, sir.
So there was a discussion going about the methods of the PD-L1 positivity. So let's say whatever the method is done, it's a very high PD-L1, something like more than 20%. By any method it is done. Will you consider it the pan PD-L1 positive, irrespective of the method, irrespective of the drug which you want to use, whether Pembro or atezolizumab? Suppose some patient is PD-L1 20 positive from the SP142. Will you consider that safely this patient will come out positivity even with the DACO22C3 also?
So I don't think too much of cross testing has been done, and fortunately in our country, the regulatory authorities, whether it be third-party insurance or it could be CGHS, ESI, the government of Rajasthan, they are as of just now not looking at how you are testing for PD-L1, whether you are testing for PD-L1 or not. But if you were practicing in Europe, or if you were practicing in the United States, then unless you do the companion recommended PD-L1 testing, the insurance would not approve. So I hope that answers your question.
So do you think that they are doing the PD-L1 testing in a metastatic breast cancer by all methods to give the information to the clinician, or they do it on demand only?
So Naresh, my take is, as per discussion with some experts from, so to say, Europe and USA are the most advanced countries. If I were to send a sample for testing to the molecular lab, then I would specify to the lab that I'm intending to use Atezo or I'm intending to use Pembro, and please look at the PD-L1 by this method or by this method. So I would direct the lab to do a testing in a particular way, and I would not leave it to the lab to do it whichever methodology they follow. All right, so with that, I think it's time to conclude. This is, further clinical trials are needed to answer several clinical questions. Whether a non-taxane backbone would be better than a taxane backbone. And there are several studies looking at this. And whether the combination of checkpoint blockage with other targeted therapies like the MEK inhibitors or the AKTI inhibitors or the PARP inhibitors for metastatic TNBC, whether this will be better than chemotherapy plus checkpoint inhibitors. And again, phase 3 studies are planned and ongoing. And with that, once again, I'd like to thank my very, very learned panel, Dr. Divesh, Dr. Aditi, both the Dr. Rohit, and the organizers for giving me this opportunity. Thank you very much. And with that, I'm going to stop sharing and hand over back to the organizers. Thank you again.
Thank you, sir. Thank you, sir. Sir, there are two questions in the chat box. One is by Dr. Lalit Mohan, sir. Is there any chance of intratumoral heterogeneity in ER/PR and HER2?
I think that was applicable to the previous discussion. Dr. Lalit himself should answer this question.
I'm sorry. I think the answer to that question is yes. If you take biopsies from two different sites in the same tumor, you can see heterogeneity. And, nobody knows how to sort that problem out. And once in a while, when you say get one particular report from Dr. Somani's lab and one particular report from Dr. Rohit's lab. So rather than, bunk those reports, just try to understand and just try to make the patient understand and support your friends and colleagues and your labs rather than, instigate the patient. So that would be my final message to everybody. Thank you.
And second question, sir, by Dr. Ankit Agarwal was, what if the PD-L1 status is unknown? Would still atezolizumab be considered if the cost is no concern?
So my answer to that is a categoric, unequivocal, unambiguous no. These are extremely expensive molecules, and as it is, you expect only a response in about 20 or 30% of patients. And this is after the marker positivity. And as per existing data, the marker positivity is a predictor of response. And for patients who do not have the markers or the marker is unknown, these expensive molecules should not be used at all. So my unambiguous answer to that question is this.
Very well said. Thank you so much, sir, for this interactive and immersive session. Thank you all Hemant sir and all the panelists. Moving on to the next session, which is also a panel discussion. The topic is triple negative breast cancer pitfalls in progress. To moderate the session, I would like to invite Dr. Lalit Mohan Sharma sir, who's a senior consultant hematologist and medical oncologist at Sri Ram Cancer Center and Mahatma Gandhi Medical College at Jaipur. And the panelists are Dr. Deepak Shukla boss, which is a consultant medical oncologist at Manipal Hospital Jaipur, Dr. Jitendra Pelajani boss, who's a consultant medical oncologist at HCG Hospital Jaipur, Dr. Ankit Agarwal boss, who's a consultant medical oncologist at Gitanjali Hospital Jaipur, Dr. Lalchand Mittal boss, who's an assistant professor at SMS Medical College Jaipur, Dr. Ankur Punia boss, who's an assistant professor of Department of Medical Oncology at Sri Ram Cancer Center Jaipur, and Dr. Lalit Sharma boss, who's a consultant medical oncologist at Manipal Hospital Jaipur. Over to Lalit Mohan sir.
So thank you so much, Dr. Somani, and thank you so much, Dr. Ankit, for your kind introduction. And I think most of the job which we will be discussing has been partly discussed. So we will be discussing the practical aspects. Before we discuss, can the organizers confirm Dr. Lalchand Mittal? I could not see him. So is he available?
Sir, he is not available, sir.
He's not available. Okay.
Yes.
Can you allow me to share my screen, please?
Yes, sir. You can share.
Okay, thank you. Right. So I've been instructed that I should not modify the point too much and should go for the practical aspects and use the same theme, triple negative breast cancer, pitfalls in progress. And metastatic disease has already been discussed by Dr. Malhotra. So we will be talking mainly on the other aspect, that is early breast cancer we'll be focusing. So I think whenever we talk about the triple negative breast cancer, this remains the common thing in our mind, that what should be done, how should we go ahead, whether the patient will show response or not, why this surgery has been done upfront. Many questions are there in mind, and most commonly with the name of triple negative, with the negativism in mind and negativism in the word, we all feel that probably this is the worst scenario. But with my learned panelists, we will try to move this negativism into positivism, and we will try to convince you that there is nothing negative. We have some positives, and we will have more and more positive news. So my panelists have already been introduced to you, and we'll start upfront with the next slide. So my question to Dr. Deepak Shukla begin with. Dr. Deepak, what is the triple negative breast cancer in your clinical practice? What percentage you see?
So, sir, triple negative breast cancer is defined as ER less than 1%, PR less than 1%, HER2 negative. So, at present, HER2 negative means 0 + 1 + 2 with FISH negativity. So, and approximately 20% patient, 15 to 20% patients are triple negative breast cancer.
Perfect. So, everyone agrees that 15 to 20% is the common thing which we see in our clinical practice. So next comes to Dr. Jitendra. Dr. Jitendra, what are the things in your mind, major worrisome points in triple negative breast cancer? Early breast cancer we are talking, not the metastatic setting.
Yes, sir. Triple negative breast cancer, as we see that they are mostly happen to be young patients in most of the scenario. They usually are very aggressive in the disease form. They do respond to the therapy, but the response is usually short time. So these are the things which do occur, and usually there are genetic mutation, familial genes which are associated with it most commonly.
Very right. So the disease is aggressive. The treatment response is short response you said, and you said that many of them are having some genetic mutations. Any other additional point, Dr. Ankur or Dr. Lalit Sharma, you want to add on to this? Worrisome points with TNBC.
Well, sir, with the chances of recurrence being high, we need to, from the very beginning, counsel these patients for a regular and stringent follow-up, especially once the adjuvant part is over, and when these patients are not on some active agent, we need to let them know that their follow-up has to be regular and strict, because many of our patients would be from far-flung places and not that well educated, so they need to understand the implications.
Agreed. Thank you. Dr. Ankit, the next question to you: how can we get better outcome with the currently available treatment modalities to us? Practical.
Sir, I think targeting a pathological CR using a neoadjuvant treatment and targeting a pathological
Excellent. So I think that sounds very good, that we target pathological CR. So there comes role of neoadjuvant chemotherapy. Dr. Ankur, any thoughts on neoadjuvant chemotherapy versus adjuvant chemotherapy?
I think, sir, for TNBC, we should give neoadjuvant chemotherapy to all the patients, because if we know and see the disease, we have to give chemotherapy. It's better to give in the neoadjuvant setting. So we'll at least know, we can be able to differentiate who people are going to have PET CR, and we will have some option further to give further drugs and to classify them, whether they are in high risk or low risk. So I would prefer we give neoadjuvant instead of adjuvant to all the TNBC patients.
Agreed. So neoadjuvant chemotherapy to all the TNBC, and as per the definition, they say if the tumor is more than 0.5 centimeter, we need to give all the patients neoadjuvant chemotherapy. Most commonly to my surgeon colleagues, that remains the importance of ER/PR, HER2 testing before we take up the patient for surgery upfront. So that remains very important point, that we do ER/PR, HER2. Triple negative, we offer them neoadjuvant chemotherapy. So next question to Dr. Deepak Shukla. Dr. Deepak, what are the, how do you treat them with chemotherapy?
So sir,
Sequence.
So in neoadjuvant setting, if we are giving, so dose dense protocol is used. So I use majority of the patients if with dose dense AC followed by dose dense paclitaxel. Routinely, I am not using carboplatin, and in the adjuvant, that means after neoadjuvant treatment based on the pathological response, I decide whether to give capecitabine or.
Agreed. I'll come to that later, in fact, capecitabine part. So we will be discussing about the bench part, that's part of laboratory part, bedside, that how best we can treat, and then how best our discussion and the modern science can reach and benefit the community. So we have discussed this part about the TNBC. Then comes the pathology part. So Dr. Ankit, in your pathology, do you see any features in TNBC, or just you see ER/PR, HER2 is negative and then label this TNBC?
I think the grade is also very important. So although
absolutely right,
the tendency of TNBC is generally we see it as a high grade, but it is very important to look at the Ki-67 and the grade.
Very right. So usually these are aggressive tumors. Grade 3 tumors are more common. Patients are younger. So these are very, very common features which we see with the TNBC. So in addition to the normal thing, any points on the lymphocytes, Dr. Lalit Sharma, any points on the lymphocyte response or TIL or something in the pathology?
Well, sir, the lymphocytic infiltration, if that is higher, probably the chances of aggressiveness would be more.
So do you see the lymphocyte response or anything in the pathology report also?
Ankit? Not sure, sir.
Dr. Ankit,
no, sir,
does your pathologist routinely report?
No, sir.
Honestly, so in fact, at our center, pathologists report it as lymphocyte response. They are not writing the word tumor infiltrating lymphocytes, but they are writing lymphocyte response. So that remains important point in our settings, other than the things mentioned here, low grade tumor, high grade tumor, and various other types of pathology part. So these are the histological part. We can see that IDC is most common and these are uncommon things. But in TNBC, we see these common things. And these are molecular things. Professor Malhotra has discussed few of them. So we will try to go for more of the practical aspects. Our pathologists are yet not able to, or we are not able to get the full idea of luminal A, luminal B, and normal like or molecular portraits or molecular classification of the breast tumors. And probably in few years, we will have more and more of the further classification. So 60 to 80% is Bajer-like. But if you see overall Bajer-like cancers, almost 70% is TNBC, and amongst them these are various mutations, TP53, RB1 loss, PIK3CA, MYC amplification. BRCA is seen in around 20% of cases, so that is also very important. And based on this, we can further classify and we can further take the advantage of these markers in the treatment decisions. Then comes the tumor microenvironment in place. So Dr. Ankur, any thoughts on the tumor microenvironment and immune infiltration of TNBC?
It's an upcoming concept in immunotherapy about the hot and cold environment, because a cold environment means a low immunogenic response and a hot environment means a hotter response. So those patients are more likely to respond to immunotherapy. So that's an upcoming thing, but we don't have a clear-cut marker to define, okay, these patients will respond, but it gives us an idea about how eventually the immunotherapy might be used in certain class of patients.
Absolutely right. So here also on the right corner of your screen, you can see these are stromal lymphocytes and these are tumor lymphocytes, and they are higher in fact in the TNBC as compared to the positives if we see. So again, that carries significance, and probably in coming few years we will be able to have more outcome based on these parameters. And this clearly suggests that the lymphocyte predominant breast cancer, we can see that this is the blue line is lymphocyte predominant breast cancer. So the outcome is higher in patients with lymphocyte predominant as compared to patients who do not have lymphocyte predominance. So even in smaller groups, also smaller tumor also, the TIL carries some significance. And now in Western world, they are doing the immunophenotype or IHC of these lymphocytes also, that what type of lymphocyte these are. And probably in few years, we will have better molecular markers that which patient will be responding to which tumor. This slide has been already shown by Professor Malhotra, that these are the three major rationale of using checkpoint inhibition, immune related thing, TILs, and we can see the TIL is higher in tumor TIL is higher in the triple negative, and we can see the PD-L1 expression is again higher in the TNBC group, and these are certain mutations. Again, Bajer-like is very, very high in the TNBC group. So this also theoretical part, I think we have discussed, and BRCA association with the TNBC. So Dr. Ankur, any thoughts on that? That do you do BRCA testing in all the TNBC?
Yes, sir. If a patient comes, if a TNBC, I advise BRCA to all the patients, irrespective of the age, because the chances of BRCA mutation coming positive is high. Particularly the family history, obviously high, but irrespective also, it's high. So I ideally recommend to all, but not able to do.
Very right. So up to 20% of the TNBC patients, it means 1 out of 5% of TNBC, they are carrying BRCA1 mutation gene positive. So very high. And I think many times we miss this part, that we do not do a BRCA testing. And few of the companies are offering some coupons also for that. So I think more and more we should do it, so that at least we can have some data about the BRCA positivity in our practical scenario. Dr. Jitendra, any thoughts at your center, that are you doing BRCA and TNBC?
Yes, sir. We are trying to do BRCA, at least BRCA for all TNBC who are curable, and we are trying to run NGS on who are mutation, who are having a metastatic disease upfront. So that's the economics is like this. We are able to do in 20 to 40% patient, but yes, we do advise.
Very right. Dr. Ankit, any thoughts on that? You are doing this BRCA testing in TNBC?
Yes, sir. We advise BRCA testing to all our TNBC patients, although it's difficult to convince patients going for BRCA testing, obviously looking at the cost issue. But BRCA should be advised to all patients who are TNBC.
Very right. Thank you. So TNBC, 20% of these patients have BRCA positive. Less than 6% of all breast cancer have BRCA mutation positive. Patients with TNBC should be offered or they should be referred to a genetic counselor. And in fact, Ankur, me and Dr. Malhotra, we are fortunate that we have a genetic counselor. We have a genetics clinic in place. So it should be discussed in the genetics clinic about the BRCA germline testing. Again, not the somatic testing, but germline testing. And it is mentioned that people who are younger or less than 60 years, they should undergo BRCA germline. It is not the somatic. Germline mutation testing they should go. So next comes about the immune microenvironment, and we have seen that PCR with chemotherapy has been discussed. So my question to Dr. Lalit Sharma, that how commonly you see PCR and what methods you use to achieve the PCR?
Well, sir, the idea is to use dose dense neoadjuvant chemotherapy and
how do you sequence that? Anthracycline first or taxane first?
Anthracycline first, followed by taxane, sir.
Right. And do you use platinum?
No, sir, not regularly.
Right. So I think that is very important that we use dose dense because most of these patients are young patients. So dose dense chemotherapy remains a choice here. And with each cycle, we keep doing clinical monitoring so that the response is continuously monitored. And at the end of chemotherapy, we see the pathological response in these patients. Dr. Ankit, if a surgeon does not send the patient to you and he is doing the surgery with a say 4 or 5 centimeter tumor with 2 or 3 node positive stage 3, what are the drawbacks of the same chemotherapy being given in adjuvant setting rather than neoadjuvant?
So first of all, when we talk about the achieving a pathological CR, we will not know what type of patient is this, whether this is a patient who would have achieved a pathological CR if we would have given it as a neoadjuvant treatment. That is, I think, the biggest drawback, that it becomes sometimes difficult to explain to the surgeon that even if it is a T2 disease, you need to send the patient for a neoadjuvant treatment. I think that is the biggest thing that we need to discuss with our surgeons.
Agreed. And in your clinical practice, how common you see the PET CR in such patients?
So with the use of neoadjuvant chemotherapy, approximately 35% of the cases, 20 to 35% is the range that we see if we are not using an immunotherapy as a neoadjuvant treatment.
Right. So 20 to 35%. Dr. Ankur, any thoughts on that, the PET CR rates?
So in TNBC, I think PET CR rates are close to 45 to 50%.
No, in practice, I'm talking, not on the theoretical aspect.
I have seen around 45%.
Right. So I think that is also good that the PET CR remains one important criteria. Dr. Deepak Shukla, do you feel that PET CR overall translate into improvement in the OS?
Sir, again, means there are now meta-analysis showing that it may transform into overall survival. In addition, one of the reasons for giving neoadjuvant treatment is that if a patient is not able to achieve a PET CR, we have a subsequent treatment which we can offer. But having said that, sir, I personally feel the ER/PR HER2/neu testing when we are doing in the neoadjuvant setting, even in my personal experience, approximately means 2 or 3 patients were having HER2/neu positive at one of the labs and triple negative in other labs. So I think this ER/PR HER2/neu is an easy test, but it needs standardization when we are using it in day-to-day clinical practice. One should be very careful.
Right. Thank you. Dr. Lalit Sharma, I think you are driving or you are sitting on the back seat. I can't guess. I'm scared. You are unmuted. You need to unmute.
I'm parked, sir, at this point in time.
Okay. Good, because I'm scared now. You can't do 2, 3 things together. Human brain is designed not to open too many files. It gets confused and problems start happening. So anyway, coming to the community setting, this study was done in Carolina breast cancer study, and they found there are a lot of black population there, and they found that in the blacks with dense breast, these are the findings they reported. That majority of the patients they reported in stage 2 or 3, and grading was higher in fact in that population, especially in TNBC. So I think we also see here the same finding. Anybody differs that we see most commonly TNBC higher grade tumors?
No, sir.
Well, so this was the TNBC in various subset of patients, and they documented that the African American premenopausal women have got higher TNBC rates as compared to the white population. But again, in our circumstances, we are seeing between 15 to 20% of the total population, and the relapses are more common, and early relapse are more common. So, Dr. Jitendra, any thoughts on the relapse pattern, that they relapse early or they relapse late, or what do you see in the clinical practice?
Sir, whatever the studies say, although majority are retrospective study, they say that majority disease fall back within first 3 years of the treatment. So after that, the chances of getting the same disease recurrence is very less.
Absolutely right. Absolutely right. Dr. Deepak, you also agree to the same thing?
Yes, sir. Actually, triple negative disease relapses early, and hormone positive can relapse 10 to 15 years down the line. So early relapses are more common with triple negative.
So within 2 or 3 years, the relapses are common, but this is long data as per the US publication in 2015, and they say that the overall relapse rate is going down. So do you also feel the same thing? Dr. Deepak, you feel the same, that our relapse rate is also going down in TNBC?
Sir, I am not keeping any data. I'm not aware of it. So not.
Dr. Ankit, any thoughts on that? That are we also seeing the same results, less relapses in early days?
Sir, I think I have a few patients who have relapsed badly in the first 2 years.
Right. So I think we need to have more and more of data, and we need to have registry here, and so that we can identify these subset and what's happening. And I think again, Dr. Somani may take lead for these also to help us. So this is again about the ISMO guidelines, as Professor Malhotra also suggested about the ISMO is more closer to us. So they say that the biology that requires TNBC, HER positive and luminal B type, we need to assess the response and prognosis, and eventually decide on post-operative therapy, and they should receive pre-operative chemotherapy. So that is very important. And even if the tumor is less than 2 centimeter, or the patient is having aggressive phenotype. So these are the aggressive phenotype, either TNBC or HER2 positive. So all these tumors, they say that we need to give systemic induction chemotherapy and then do surgery, maybe whatever type of surgery, and then we need to give the post-op treatment. So I think most of us also follow the same thing. And whenever a patient comes to a physician, the management is better as compared to the other types of oncology, with due respect to my surgeons and radiation guys. NCCN say that achieving a PET-CR to neoadjuvant therapy is associated with favorable disease-free and overall survival in early breast cancer. So I think that is true, that we also try to achieve the PET-CR, and for us it remains a marker. Dr. Beniwal also in the morning highlighted the importance of PET-CR, and we all agree to that part. This, I think, is for advanced disease where PD-L1 testing, we will not go into the testing part. So the next question to Dr. Ankur. Dr. Ankur, role of platinum, where do you add the platinum compounds?
So, although there is a conflicting data, sir, but still there is a good enough data that we should add platinum in the neoadjuvant setting along with the taxane, because it has shown in 2 trials to improve the PET-CR rate, but also in the BRCA positive population, addition of platinum improved the PET CR. So it's better to add in the neoadjuvant setting, because in adjuvant setting, it is not clearly shown any benefit. Only I think one trial showed, and most of the trials have not shown benefit in adjuvant. So if you have to add, you should add in neoadjuvant setting.
So in your practice, you give platinum or you don't give platinum?
Most of the patients that I give platinum.
Very good. So you give the platinum. Dr. Deepak, you also give platinum to almost all patients?
No, sir. Actually, I am not that convinced. There is conflicting data, and possibly the maximum benefit. Possibly one time I consider is possibly after 4 cycle of dose dense AC, patient has not had a very good response. Possibly in that setting with the paclitaxel, I can consider adding carboplatin, but routinely I am not using.
Dr. Lalit Sharma, you add platinum or you don't add platinum?
So usually I don't add platinum. Two scenarios where I might consider is, one is if there is no recent clinical response after 4 cycles of AC, or a younger preserved patient with higher tumor burden such as locally advanced, I might consider.
Dr. Jitendra, any harm in adding platinum? If I see in the practice, we get only one chance. Our patients hardly go for the second line treatment in metastatic setting. So our patients are compromised and we need to hit very hard. So whatever is available to us, immune checkpoint inhibitors and PARP inhibitor and all those looks good on discussion on the computer and on the platform. But when it comes to real life situation, what is the harm in giving platinum?
So the point is, we all medical oncologists understand that we have to understand the disease in vivo, in the patient. If the patient is responding well, we are well sure that with the AC we have a good response, more than 60-70% reduction, which usually we see. But if we add platinum to all patients, then probably we will not being justified to add the capecitabine, which has proven benefit in an adjuvant setting sort of thing.
Dr. Somani, you want to make some comment on this?
I would like to add the 3.1, agreeing with Dr. Deepak Shukla, that if there is no good response to AC remsacycline, then that is the one scenario. Second, in the neoadjuvant in the TNBC, if I'm going to use for immuno-oncology drug for my patient, then maybe the taxane with the platinum is the one thing. Second question, third question which comes in my mind and which I need the answer from the panelist is, suppose your patient is a BRCA positive in the metastatic setting, and you are not able to use the PARP inhibitor due to the cost factor. Are you going to use the platinum in this group of the patient as the surrogate marker that the BRCA may be giving the more sensitivity to the platinum also?
So in metastatic settings,
left with 5 minutes to conclude your panel discussion. Thank you.
Sir, I think in metastatic setting, platinums should be used if you are not able to use olaparib as a surrogate marker, because there have been few trials in which single agent carboplatin has been compared to docetaxel, especially in those patients who had BRCA positivity. Carboplatin had shown a very good response rate as compared to dosi. So I think it's a good thought to use platinums in metastatic disease along with the either a taxane or gemcitabine, what we are using as a standard treatment if you are not able to use olaparib.
I think sounds good. So next comes about the surgical benefits. We all know about the whenever we expose the patient with neoadjuvant treatment, many of these patients, they are converted, like here in this particular study, we can see 42% converted to breast conservation surgery. And we can see that the axillary clearance, that out of 153 node positive, 67% converted to node negative. And what is being practiced and discussed on US platform, the combination being discussed and being practiced by my dear friend Dr. Surinder Beniwal also in Bikaner. He was sharing about the same protocol, Pacli, Carbo and Bev. So we can see that this leads to good improvement, and we will also check that if this type of chemotherapy can make some difference. This we have seen that about the overall PET CR, we know that this translates into good outcome and success. One word about Dr. Ankur, any thoughts about the CREATE-X trial or the maintenance therapy?
Yes, sir. For the patient who doesn't achieve a PET CR post neoadjuvant chemotherapy, adding capecitabine has improved disease-free as well as overall survival as shown in this trial. So I will definitely add for these patients.
So everyone adds that capecitabine, or any thoughts on that also?
So, sir, if a patient has not achieved pathological CR, so in that setting, I am adding. Also, sir, there is a Chinese trial because many of our patients come to us after undergoing surgery. So there is some data for giving capecitabine for a year. So I don't give it for a year, but some of the high-risk patients who have been operated upfront, who are having node positive, somewhat similar to Createx, I give 6 to 8 cycles adjuvant capecitabine, knowing that the data is not that strong.
Absolutely. So in practice, I also sort of practice the same thing, because I am always scared of the relapse. In fact, that if a patient relapses, the whole exercise goes futile. So I also use capecitabine in the setting where the disease is high risk, upfront surgery has been done, or the patient did not achieve a PET CR. PARP inhibitor, I think we have discussed partly, and then comes the immune checkpoint inhibitor in TNBC. So, Dr. Jitendra, can you throw some light that where will you use immune checkpoint inhibitors?
So, actually, as you know, that immune checkpoint inhibitors are not that much well studied in this scenario still date. In neoadjuvant setting, although we do have data, but only adjuvant setting we do not have that much strong data.
We're talking about neoadjuvant, like the trial 522.
Definitely, we should do something to improve the PCR, as we have already discussed that PCR is the main goal for now for us. So in patients who are BRCA negative, probably I would like to add in neoadjuvant setting.
Dr. Naresh Sharma, any thoughts on that?
Well, sir, in PDL positive patients, I would like to consider giving best shot. So definitely like to consider in neoadjuvant setting.
Dr. Ankur, if no financial barrier, you will use Atijo or Pembro?
We have evidence, more stronger evidence with Pembro, sir. I will add pembrolizumab for TNBC in neoadjuvant setting.
Great. So I think that sounds good. That generally it leads to increase in the PCR rates, and the benefit is not related to PDL1 status. Unlike in metastatic disease, and PDL1 positive patients have higher PCR with chemotherapy along with the ICI. And we have seen this part, and I will not go into the detail into the interest of time. And I think while the triple negative breast cancer is most likely the basal type on intrinsic subtyping, biological heterogeneity comes from the tumor and from the microenvironment, and probably we will have some markers like TIL or Ki67 or something in hand to guide us about the treatment part. Cure rates have improved, in fact, based on the neoadjuvant understanding of treatment. And in metastatic setting, also the treatment outcome has improved. And these patients, the genetic counseling remains one important point here. So with this, I end up, and I thank all my panelists for the excellent discussions. And I thank Dr. Somani, I thank Tarun Mathur and team for supporting us. Thank you so much.
Thank you, sir. Sir, we have two questions in the chat box, both by Somani, sir. One is role of PARP inhibitor in adjuvant setting in BRCA positive breast cancer.
So, Dr. Deepak Shukla,
yes,
can
sir.
you tell us about the PARP inhibitor in adjuvant setting?
So, sir, definitely, I think this is the one drug I think we should strongly consider, because the distance disease-free survival was reduced by close to 8%. So I think for BRCA mutated patients, particularly in the neoadjuvant setting, if patients have not achieved a pathological CR, and for the patients who have undergone surgery are node positive more than 2 centimeter, triple negative should be considered. And I think there is good data. I think it will be means only reason we are waiting, we do not have an approval at present in India. And possibly we do not have OS data at present, but I think this will become a standard practice.
Very, very right. Thank you. So I think with this we end up the pen. Any other questions?
Yes, sir.
That was a comment on, yeah.
Question is how frequently you do FISH testing in HER2 1+ positive patients? to confirm HER2 by FISH.
Dr. Ankur Punia has already mentioned that IHC 1+ does not need any FISH testing, only it is for IHC 2+ for the HER2 needs FISH. Thank you.
Very well said.
So thank you so much, Dr. Ankit.
Thank you, sir. Thank you, sir, so much for the very engaging and informative session. Lalit Mohan sir, panelist. Moving on to the next session, which is a pharma session. I would like to Dr. Deepak Shukla sir, who is a consultant medical oncologist, Manipal Hospital, Jaipur. He'll be talking about redefining the standard of care in post-menopausal, hormone-positive, HER2-negative advanced breast cancer. Over to
so Dr. Ankit, may I correct you that this is a sponsored session. We call this as a sponsored session, not a pharma session. So this is sponsored and supported by the pharma. Thank you.
Okay, sir. Thank you.
Thank you, Dr. Ankur. I'll be speaking on redefining treatment in hormone-positive metastatic breast cancer. Are my slides visible?
Yes, very much.
So I am going to speak on redefining the standard of care for postmenopausal, hormone-positive, HER2-negative advanced breast cancer. So it is a Novartis sponsored session, but we'll discuss the most recent practice-changing data that we have seen in the last ESMO. So I'll discuss this topic under the following headings. So we'll discuss the current approach. As mentioned, the Mona Lisa 2 study recently presented, and the ribociclib comparison with other CDK4/6 inhibitors, and then I'll summarize the topic. So the goals for treatment in advanced metastatic breast cancer, like any other cancer, is like any other advanced cancer, is to prolong survival, restrict treatment-related toxicity, improve symptom, and also improve the quality of life. So for hormone-positive metastatic breast cancer, I do not know the authenticity of this picture, but this is a publication in Lancet 1996, where the surgeons have performed oophorectomy in females, and they found that their metastatic disease or breast cancer used to means reduced with this treatment. And now we know that for hormone positive, HER2 negative advanced breast cancer, the endocrine treatment has become the mainstay of treatment. And what is new in the last decade or so, or last 5 to 6 years, is the incorporation of the CDK4/6 inhibitor, either in the first line setting or second line setting. So one may argue regarding the survival advantage, but for sure this treatment has to be given to a patient either in first line, second line, if financial burden is not there. And in the subsequent line, based on the Bolero trial, we can give exemestane everolimus, or based on the Solar trial, in patients who are PIK3 kinase mutated, fulvestrant with alpelisib can be used in the second line setting. So the hormonal therapy is the mainstay of treatment for hormone positive, HER2 negative metastatic breast cancer, and this is endorsed by various guidelines. So what we know is that the CDK4/6 inhibitors, when combined with aromatase inhibitors in the first line setting, give us a response rate of close to 40 to 50% and a median PFS of close to 2 years in this setting, and it has been supported by the recent ABC guidelines also. So there is in addition to what we have seen clinically, there is a clear role of CDK4/6 inhibition in advanced breast cancer. So CDK4 plays the key role in breast cancer tumorigenesis and cell proliferation. The levels of CDK4 are upregulated more than 8 times as compared to CDK6 in breast cancer cell lines. And inhibition of CDK4 has been shown to block the ability of breast cancer cells to form tumor. The available drug, when penetrates the tumor cells, binds and inhibits CDK4, and that is the biological rationale of giving a CDK4 inhibitors. Coming to the cellular pathway, the hormone positive breast cancer is driven by the estrogen signaling, and it leads to stimulation of cyclin D1 production. This cyclin D1 in turn activates CDK4 and 6, and the selective inhibition of CDK4/6 causes the cell cycle arrest in G1 phase, resulting in reduced cell viability and tumor shrinking. So this endocrine therapy in combination with CDK4/6 inhibitor, in addition to blocking the estradiol or the estrogen receptor, also inhibits the downstream pathway, that is the CDK4/6 inhibition. And this biological synergy has been seen to transform in the clinics, as we'll discuss subsequently. So when we are deciding to choose any hormonal endocrine treatment with CDK4/6 inhibitor, there are lots of consideration. This is a metastatic breast cancer setting, what we are discussing. Now we have data for abemaciclib in the adjuvant setting, but in the metastatic setting, the patient, what treatment he has received, is he a de novo metastatic hormone positive breast cancer, whether the patient is having visceral crisis, or whether the patient is premenopausal or postmenopausal, knowing that majority of the premenopausal or all of the premenopausal patients are converted to postmenopausal either by medical or surgical oophorectomy. The side effects when choosing an endocrine treatment takes into consideration the drug side effects. When choosing the partner CDK4/6, again, drug side effects need to be considered patient to patient basis. And also we know that the two of the drugs available to us and with the CDK4/6 inhibitor setting are given continuously. The other one is given 3 week, 1 week off. Some, it may be a consideration in few of our patients. And the finances, which often in the clinical practice is the first point which drives the treatment what we are giving, is very important. So what we know till now is that CDK4/6 inhibitor, when given with an hormone positive HER2 negative advanced breast cancer, across the drugs have shown improvement in PFS, overall response rate, and clinical benefit rate when compared to endocrine treatment alone. But we have, and what I have said is descriptive in this table. So we have in 2015 with the approval of palbociclib in the in combination with letrozole or fulvestrant, it has shown in PALOMA-2 trial to improve PFS, and across the board in the MONALEESA-2, MONALEESA-3, MONARCH-3, and MONALEESA-7, we see approximately a PFS benefit of close to 2 years, a response rate of close to 40 to 50%, and across the trials we see a similar hazard ratio close to 0.5. So all of these drugs, when we look into the hazards of PFS, are working similarly. So do all CDK inhibitors have shown improvement in overall survival, which in a cost constraint setting in which we are working is, I think, the goal to decide any treatment, leave alone CDK4/6 inhibitor. So in this particular setting, ribociclib compares very well as compared to the other two drugs. So ribociclib, based on the data recently presented from MONALEESA-2, in the first line postmenopausal setting in combination with an AI, has shown to improve overall survival. In the second line setting, including the first line setting in the MONALEESA-3 in combination with fulvestrant, it has shown improvement in survival. And also the only trial done absolutely in the premenopausal setting also showed an overall survival. While when we compare it to the other two drugs available, so for abemaciclib in the first line setting, the data is pending. The data for of combination of abemaciclib with fulvestrant has shown improvement in overall survival. While for palbociclib, PALOMA-3 failed to show improvement in overall survival in the ITT population, while the results of PALOMA-2 are awaited. So as already discussed, this is the most recent data that was added to our armamentarium that was not available to us. So the MONALEESA-2 was the largest first line study done in postmenopausal women. This was a phase 3 trial. It investigated combination of ribociclib with letrozole in the first line setting in postmenopausal hormone positive HER2 negative advanced breast cancer. What we knew that it improved PFS by close to 10 months, and recently the overall survival data has been presented. So just a quick overlook into the trial design. This was a phase 3 randomized double-blind placebo-controlled multi-center trial. So the best study design what one can accept from a phase 3 design. So it included patients who were postmenopausal hormone positive HER2 negative suffering from advanced breast cancer. They have not received any previous treatment, or if they've received any neoadjuvant or adjuvant endocrine treatment, the relapse had to offer after 1 year. So it was a hormone sensitive population of close to 660 patients that were enrolled. The primary endpoint was progression-free survival, while the key secondary endpoint was overall survival, and close to 330 patients were randomized to each of the arm. What we saw recently that was reported in ESMO in September was that ribociclib in combination with letrozole improved overall survival by close to a year, and 24% relative reduction in the risk of death as compared to the endocrine treatment alone arm. And what is particularly encouraging to see that over time, the overall survival benefit improved with addition of ribociclib. So at 4 years in this study, the difference was close to 6%, which improved to 12% in the last follow-up at 6 years. And the 6-year survival rate of patients receiving ribociclib was 44.2%, which is truly remarkable and shows how the journey has been so far with the with the use of the CDK4/6 inhibitor in the first line setting. If we look into the subgroup analysis of these of this data, so all of the subsets benefited. What benefit means the maximum benefit was seen in patients in having de novo metastatic disease, while the magnitude of benefit was lower when patient has relapsed after previous endocrine treatment, and the number of metastatic site need not matter. So less than 3 and more than 3, both of them benefited. And also one of the goals for us when we are treating hormone positive metastatic breast cancer is to delay initiation of chemotherapy. So we used approximately 2 to 3 lines based on the hormone sensitivity. And the trial showed that by using this combination, we can delay chemotherapy by close to a year as compared to when endocrine therapy is given alone. And it is important to note that approximately at 5-year follow-up, close to 10% patients are still on the ribociclib letrozole arm as compared to 5% in the placebo letrozole arm. And the adverse effect profile was predictable, manageable, and reversible. There were no new safety signals. And what MONALEESA-2 further gives us evidence to that possibly this is a well-tolerated drug with the highest level of CDK4/6 inhibition that we knew previously, which has transformed now into a clear overall survival benefit. And the ribociclib, as compared to other CDK4/6 inhibitor, preferentially target CDK4, and also the free drug concentration is more. However, having said that, the major safety concerns are different for the 3 different CDK4/6 inhibition, and always should be kept in mind when choosing the partner CDK4/6 inhibitor. So with ribociclib, QT prolongation, LFT abnormality, and hematological toxicity are there. For abemaciclib, we know that diarrhea is the main side effect. For palbociclib, hematological toxicity is a concern, and but as such, for ribociclib, based on this data, it is having a manageable safety and tolerability profile. So just to summarize the talk, ribociclib in combination with an AI has shown the longest reported median overall survival, approximately 30% reduction in risk of death across the trial, It delays use of chemotherapy. It improves and preserves quality of life, and it has shown manageable safety. Thank you.
Thank you, Deepak boss, for the excellent talk. And in the comment box, Naresh sir has put a question, but well answered that. What is the advantage of ribociclib in the session? So our next talk, I would like to invite Dr. Mukesh Tolania, who is Assistant Professor, Department of Medical Oncology and BMT at State Cancer Institute, Jaipur. He'll be talking about role of atezolizumab in metastatic triple negative breast cancer in PD-L1 positive patients. The talk is sponsored by Roche Pharma. Over to Dr. Mukesh. Dr. Mukesh?
Yes. I am sharing my slides. So now my slides are visible now.
Yes, sir.
So role of immunotherapy in metastatic TNBC is my topic. So today I discuss about the role of immunotherapy, how it started in TNBC patients. As we know, breast cancer is the most frequently diagnosed cancer in humans worldwide and ranked second among causes for cancer-related death in women. As we know, evidence in literature have shown that the past and ongoing research has an enormous implication in improving the clinical outcomes in breast cancer. This has been attributed to the progress made in the realm of screening, diagnostic, and therapeutic strategies in getting breast cancer management. However, we know poor prognosis in TNBC and drug resistance present major inhibitions, which are also current challenges for containing the disease. As we know, breast cancer is a heterogeneous disease comprising multiple entities associated with distinct histological and biological features, clinical presentation, and behavior and response to therapy. Recently, by microarray-based technologies, we have unraveled the molecular profiling of breast cancer, including metastatic propensity and histological grade, and have led to the identification of prognostic and predictive gene expression signatures. And furthermore, a molecular taxonomy of breast cancer based on transcriptomic analysis has been proposed. However, microarray studies has primarily focused on invasive ductal carcinoma of no special types. So classification of breast cancer according to histology and molecular markers, as no breast cancer is usually divided into two types: in situ. In situ is two types: ductal and lobular, and invasive carcinoma. And in molecular subtypes, luminal A, luminal B, HER2 enriched, and basal-like. Among the invasive carcinoma, we know the IDC, the most common subtypes, accounting for 70 to 80% of all invasive lesions. And IDC is further classified as either well differentiated, moderately differentiated, or poorly differentiated, based on the level of nuclear pleomorphism, glandular formation, or tubule formation. So prevalence of histological types of breast cancer in various studies, as we know, most common is invasive ductal carcinoma. And also we know that TNBC are most commonly is basal-likes in molecular classifications. And TNBC usually have histological types of medullary or adenocystic types. So coming on the TNBC, as we know, incidence of TNBC is approximately 15% of breast cancer worldwide. Currently, TNBC is highly prevalent among Indian women, and incidence being around 30%, and 52% of these patients in advanced and metastatic disease. And age group is predominance is mainly minimum around less than 50 years. Minimum age is 22 and maximum age of presentation is 75 years. So as we know, the TNBC like expression of ER/PR and HER2, approximately 80% of TNBC fall into basal-like subtypes of molecular breast cancers based on gene expression analysis. And 6 unique subtypes identified to date of TNBC are mesenchymal immunomodulatory, basal-like 1, basal-like 2, mesenchymal stem cell-like, luminal androgen receptor-like, and unclassifiable. So what are the basic characteristics of TNBC? As we know, more likely to have grade 3 histology, poorly differentiated, large tumors at the time of diagnosis, higher mortality rates, more aggressive disease, and higher rate of distant recurrences, and often present as advanced stage disease, so required significant unmet medical needs. So clinical outcomes for patients with TNBC, higher risk of spread outside the breast within first 5 years after diagnosis as compared to other breast cancer subtypes. And mean time for distant recurrence is lower for TNBC as compared to other breast cancer subtypes. And decrease in 5-year survival with TNBC as compared to other breast cancer subtypes. And median survival for women with metastatic TNBC is less than 1 year. Almost all patients die from the disease despite aggressive systemic chemotherapy. So TNBC survival rates are lower than for other breast cancer histological types. They have minimum survival rates as compared to other histological types. Relative 5-year overall survival for TNBC was poorer than for other type of breast cancer. And compared with other breast cancer subtypes, we know that patients with TNBC have high proportions of recurrence, lower mean time to distant recurrence, shorter mean time to local recurrence, and TNBC patients have more likely to metastasize to lungs and brain, and less likely in the metastasis to bone. So in TNBC, high unmet clinical needs because overall survival is worse than in other form of breast cancer, recurrence rates which are very high, aggressive tumor, heterogeneous disease that needs further segmentation into treatable subtypes. Treatment options are very limited, particularly in the metastatic TNBC. So coming into the immunotherapy part in metastatic TNBC, I briefly discussed about the basic knowledge of immunotherapy. As we know, T-cell infiltration is very important for immunotherapy efficacy. And we know that T-cell infiltration among the breast cancer type have maximum in TNBC. Usually, TIL, T-cell infiltration in tumor is divided in 3 types: low, intermediate, and high. Low is 0 to 10% of tumor infiltrant lymphocytes in tumor stroma. 11 to 59% is intermediate, and more than or equal to 60% is high. TIL infiltration is considered high T-cell infiltration. So TNBC patients around 30% have more than 60%. As we know, the cancers are characterized by gene mutations and poorly functioning cellular regulations, and these results in expression of new or differentiated antigens that are recognized by the immune system as being foreign and different from healthy cells. And we know TNBC shows a high mutation rate estimated by 13 times relative to normal cells, and they may produce new antigens that could induce an immune response. For an effective immune response, we know activated effector T cell must traffic to the tumor sites and infiltrate the tumor. Primary TNBC tumor shows increased level of TIL compared to other breast cancer subtypes. And T-cell infiltration in TNBC is associated with improved prognosis for patients. And for each 10% increase in the level of stromal tumor infiltrating cell, 19% reduce the risk of death, approximately 15% reduction in the risk of distant recurrence, and approximately 15% reduction in risk of recurrence or death. So expression of PD-L1 in the tumor microenvironment on both tumor cells and tumor infiltrating immune cells can inhibit anti-tumor response. And PD-L1 expression has been observed in more than 15% of advanced TNBC patients. And PD-L1 positive TNBC have a higher average number of CD8 positive T cells versus PD-L1 negative TNBC. And therapies targeting the PD-1 pathway may therefore enhance the immune response. So PD-L1 expression is higher in TNBC patients as compared to other breast cancer subtypes. So there is definitely role of immunotherapy in TNBC. So The PD-L1 pathway down-regulates the anti-cancer immune response at two different levels of hallmark of cancer. First is priming and activation. As we know, PD-L1 expressions prevents T-cell priming and activation in the lymph node and killing of cancer. PD-L1 expression leads to the inhibition of the anti-cancer T-cell activity in the tumor microenvironment. So up to recently, there is limited drugs available for metastatic TNBC. As we know, in metastatic breast cancer first line, we use taxanes if disease-free interval is more than 1 year, or platinum combinations. And in second line, there is capecitabine, carboplatin, gemcitabine, eribulin. Third line, yeah, either base supportive care, and if you use eribulin second line, then can we use third lines? So most active agents in the first line settings are anthracycline and taxanes, which can be used either as single agents or as a part of combination regimens. As we know, combination increases response rates. They are also associated with more toxicity and do not provide any survival advantage in comparison with single agents. So how to choose between single agents or combinations? Such variables can affect like performance status, risk of adverse events, prior chemotherapy regimens, disease burden, and patient preference must be considered. So survival outcomes with various chemotherapy regimens in metastatic TNBC, as we know, maximum with eribulin and carboplatin and gemcitabine. So summary for treatment options for metastatic TNBC, as we know, metastatic TNBC is currently incurable. Main state of treatment is chemotherapy, usually with single agent and sometimes with double agent. International treatment guidelines provide recommendation on the most effective therapies in metastatic TNBC, treated usually with palliative chemotherapy with eventual transition to palliative care. So first study of immunotherapy in metastatic TNBC is IMpassion 130 trial. This trial included metastatic on inoperable, locally advanced TNBC, histologically documented, no prior therapy for advanced TNBC. Prior chemotherapy in the curative setting included taxanes, allowed if treatment-free interval is more than or equal to 1 year. Included only ECOG PS 0 and 1 and only PD-L1 status. And they compared Tecentriq plus nab-paclitaxel versus placebo with nab-paclitaxel. Primary endpoint is PFS and overall survival in the ITT and PD-L1 positive populations. Secondary endpoints, they choose overall response rate, DOR, and safety analysis. So this phase 3 Tecentriq study in metastatic TNBC used chemotherapy background as a nab-paclitaxel. Unlike solvent-based paclitaxels, as we know, nab-paclitaxel does not require steroid pre-medication to lessen the risk of hypersensitivity allergic reactions. And also we know that real data demonstrated similar overall survival and time to next treatment in patients treated with nab-pacli and pacli, suggesting that agents may be considered interchangeable as first-line treatment for metastatic TNBC. So what is the dosing schedule of nab-paclitaxel in this study? As we know, weekly dosing of nab-paclitaxel most commonly utilized schedules given its better tolerability and suggestions of increased efficacy versus thrice weekly dosing. The difference in the efficacy between the 100 mg versus 150 mg per meter square weekly dose level of nab-paclitaxel was no different, while the safety profile was better with 100 mg per meter square. The dose of Tecentriq was, as we know, the 100 mg every 5 weekly, but in this study administered every 2 weekly due to nab-paclitaxel dosing. So this is study schema. Statistical testing followed a strict hierarchy designs. The primary PFS analysis, PFS stated in ITT population initially, and then PD-L1 population is parallel. If both are results positive, a small amount of alpha was assigned to test overall response rate. Then OS testing, first interim or OS analysis was done sequentially, first in ITT population, then if statistically significant, then PD-L1 positive patients. A total of 2 interim OS analysis done in this study, and or one final analysis was also run. And the study had 95% power for the primary analysis of PFS in ITT patients and 88% power for overall survival. So this is a study schema, and we know that placebo arm and Tecentriq arm are well balanced in compared to race, ECOG, site of metastatic disease like lung, bone, liver, and brain. So this is first interim analysis, primary PFS. In ITT population, as we know, there is a PFS benefit of 1.7 months in Tecentriq with nab-paclitaxel as compared to placebo with nab-paclitaxel. In PFS analysis by PD-L1 status, definitely there is a higher PFS with in PD-L1 positive patients as compared to PD-L1 negative patients. And at interim OS analysis, a 3.7 numerical difference in median overall survival was observed with the addition of Tecentriq to nab-paclitaxel. This was not statistically significant at the first interim analysis. But in OS analysis by PD-L1 status, in PD-L1 positive patient, there is overall survival benefit in ATTE with nab-paclitaxel as compared to placebo with nab-paclitaxel. PFS subgroup in ITT populations, and this is so that PFS is benefit was primarily seen in the PD-L1 positive subgroup, but there were no detrimental effect of Tecentriq in the PD-L1 negative group also. And according to
Dr.
response
Mukesh,
rate,
sorry to interrupt. Only 1 minute left.
Yes, yes. Numerically higher response rate are observed with Tecentriq and nab-paclitaxel versus placebo and nab-paclitaxel. Coming to adverse events, as we know, high hepatitis rates were well balanced and generally driven by laboratory values rather than clinical diagnosis. All hypothyroidism events were grade 1, 2, none lead to treatment discontinuation with Tecentriq. Pneumonitis was very rare. Most common adverse events, regardless of attributions, the most common adverse events were generally similar between two arms, and a higher proportion of patients in the Tecentriq arm reported at 23% as compared to 18% only. The updated safety and efficacy analysis, a secondary analysis showing that the OS in ITT population is higher in Tecentriq with nab-paclitaxel as compared to placebo with nab-paclitaxel. And also is overall survival benefit in PD-L1 positive patient is higher as compared to placebo with nab-paclitaxel. Updated safety analysis, there is a well-balanced safety with nab-paclitaxel atezolizumab as compared to placebo nab-paclitaxel. So key learning points and clinical implications of this study. IMPASSION 130, the first phase study to demonstrate a benefit with cancer immunotherapy in metastatic TNBC. The benefit risk profile of Tecentriq with nab-paclitaxel support a change in practice in the first-line treatment of TNBC. Higher PFS rates, higher PFS rate in PD-L1 positive patients, and clinically meaningful median overall survival of 25 months in PD-L1 population, PD-L1 positive patients, and no new safety signals. To summarize, high incidence of TNBC in India. TNBC is associated with high relapse rate and overall poor prognosis. Treatment options are very limited in the current settings. No new adverse events are reported in this study. A clinically meaningful 25-month overall survival benefit was observed with addition of the Tecentriq. IMPASSION is the first phase 3 study to demonstrate benefit with cancer immunotherapy in metastatic TNBC. However, US FDA withdrawal of TNBC indication and implications for India, because Tecentriq is initially approved as accelerated approval and later it withdrawn by FDA because no overall survival, meaningful survival was demonstrated in the final analysis. But no new safety or efficacy data informed this decision to withdraw the indication. The benefit risk of Tecentriq in this population remains unchanged. The FDA emphasized that the decision is supported by current US regulatory processes, rule for accelerated approval, and was not a decision based upon clinical factors. So, furthermore, we look forward to completing and reading out our ongoing phase 3 study investing Tecentriq in TNBC both in early and metastatic disease. Thank you.
Thank you, Dr. Mukesh, for the third time for being so crisp, right on time, and excellent talk. Moving on to the next talk, again sponsored by Roche. I would like to invite Dr. Divesh Goyal sir, who is a senior consultant medical oncologist at Fortis Hospital, Jaipur. He'll be talking about Catherine trial, which is a HER2 positive shifting paradigm in early breast cancer treatment.
Yeah.
Over to Divesh sir.
Yeah. Thank you, Ankit, and thank you, Sumani sir, for giving me today as present as a opportunity. And thanks, Roche. And I'm just sharing my screen. Is my screen is visible?
Yes, sir.
Okay. So just
perfect, sir.
We will discuss the role of Kadcyla, means trastuzumab, trastuzumab, emtansine in this adjuvant treatment for HER2 positive early breast cancer. As we all know about this HER2 positive disease, and we all know how can we treat, how we are treating since long years. So the rationale and study design. So in this early breast cancer, the treatment of goal is the cure. So there is, therefore, patient should be given the most efficacious treatment that is available. Almost 78% of metastatic breast cancer are due to early breast cancer relapse, and breast cancer recurrence has a significant impact on quality of life. So there is currently no cure for HER2 positive metastatic breast cancer. So there is certain decision points to define treatment to an individual's needs. Initial diagnosis take into accounts, followed by the further aim of neoadjuvant therapies to reduction of tumor size, renders operable and de-escalated surgery. And following this surgery, in this surgery, removal of all detectable disease in this breast as well as nodes. And following this, further pathological assessment of residual invasive disease, whether the patient have residual invasive disease or PATH-CR. And following this, further we can decide the adjuvant treatment. So aim of this adjuvant treatment is elimination of residual invasive or micrometastatic disease to prevent metastatic recurrence in this curative setting. So based on this current scenario, guidelines, HER2 positive early breast cancer should receive neoadjuvant systemic therapy. These mentioned in NCCN, ESMO, St. Gallen's and AGO guidelines. In NCCN, HER2 positive tumors should be treated with preoperative systemic therapy incorporating Herceptin, and a Perjeta containing regimes, that is the pertuzumab, may be administered preoperatively to patient with T2 or more than T2 and N1 or more than N1 HER2 positive early breast cancer. So this the pertuzumab plus trastuzumab is recommended by the international guidelines for NACT with high risk HER2 positive early breast cancer. So this neoadjuvant therapy offers several benefits. It enables early response assessment. So this will define the provide in vivo assessment of response, and it provides an opportunity to adjust adjuvant treatment that depending on the outcome of a neoadjuvant treatment. And it will also enhance the surgical options, that is the downstage breast tumor, means leading to improved chance of conservative surgery, downstage axilla avoiding axillary dissection, potentially decreasing surgical morbidity, and allows times for planning reconstructive surgery. And benefit of this early systemic treatments so that allow early treatment of micrometastasis. So based on this NeoSphere trial, the pertuzumab plus trastuzumab combination plus chemotherapy is standard of care for NACT for high risk HER2 positive breast cancer. As shown in this graph, the phase 2 study of this pertuzumab in this NACT, if we are using single agent trastuzumab, there is compared with this Perjeta and Herceptin combination. So there is the PATH-CR probability is more in this Perjeta plus Herceptin group. So it will definitely increase pathological CR rates versus single agent, leading to the approval of Perjeta in this neoadjuvant setting. So various guidelines also recommend for this Perjeta and Herceptin combination with chemotherapy in NACT for HER2 positive early breast cancer. So this neoadjuvant pertuzumab plus trastuzumab supports the downstaging as well as surgical de-escalation. So PATH-CR rates were higher in patient treated with this combination compared with this trastuzumab plus chemo only, and only 75% of 51 patients achieved downstaging to the breast conservation surgery. So 86% of patients treated with this combination achieved downstaging to this breast conservation surgery. So this is almost comparable to the mastectomy for all tumor as well as patient variable. So long term, the relapse rates, local recurrence rate with the tumor downstaging and BCS are similar to those for traditionally mastectomy with adjuvant therapy. So this LRR rate was 10.3% for this BCS plus RT compared with this 12.6% for mastectomy without RT after 10 years for follow-up. So no increase in complication even with immediate reconstruction. So the prior to Catherine, the 18 cycles of this the hertuzumab plus pertuzumab were advisable for this HER2 positive early breast cancer that was high risk of recurrence or death irrespective of neoadjuvant response. So the newly diagnosed high risk HER2 positive breast cancer surgery followed by this dual blockage of 18 cycle. And if we are using this neoadjuvant 4 to 6 cycle followed by the surgery and further 12 to 14 cycle. So patient received the same standard of care of treatment in this adjuvant setting regardless of response to NACT due to lack of evidence to support changing therapy. So again, the 5-year DFS were more in this both combination group, 84% versus the 81% 5-year DFS. And again, in affinity is this 6-year IDFS. So is this invasive disease-free survival is better in this combination of Perjeta plus Herceptin versus this placebo plus Herceptin. That is the 0.81 in this hazard ratio significant, and also updated descriptive analysis 0.76. So this outcomes of neoadjuvant therapy in this to determine pathological response or further residual disease. So NSCT was given if there is no disease or in situ residual disease, almost total pathological CR. So no malignant cells were found on surgical specimens. So responsive to treatment, still they are at risk of recurrence of death, and sometimes there is incomplete response to treatment and significant risk of breast cancer. So there is residual macroscopic or microscopic disease present in this breast as well as axilla. So this may be a residual disease, may be an invasive disease after the neoadjuvant HER2 targeted therapy have a worse prognosis than those who achieve a path CR. So as shown in this various trial, Techno, Gepar, Quinto, Henna as Neosphere and Trefena. So they all show that neoadjuvant HER2 targeted therapies following this the residual disease following this neoadjuvant treatment have worse prognosis than those achieve a pathological CR. So despite the proven benefit of neoadjuvant HER2 targeted treatment, some patients with this HER2 positive early breast cancer are still at risk of recurrence. Almost 40 to 60% of patients will have residual invasive disease after dual blockade HER2 targeted therapy. So it is important to adapt the early breast cancer treatment to avoid recurrence as well as progression to incurable MBC. Data for the CREATE-X trial in TNBC and Catherine trial HER2 positive breast cancer have provided evidence to support adapting treatment for patients with residual invasive disease following this NSCT and surgery. So the presence of residual disease informs a new clinical decision point to tailor treatment in this adjuvant setting. So initially, the newly diagnosed high-risk HER2 positive early breast cancer with tumor 2 or more than 2 centimeter with node positive, NSCT for 4 to 6 cycles surgery and followed by the assessment of residual disease. Whether there is a complete path CR, so in this continue this the dual therapy in adjuvant setting to complete 18 cycle, and where there is a residual invasive disease, so there is a change treatment to the Kadcyla for 14 cycle in this adjuvant setting. So the prior to Catherine, there were no data available to guide treatment decision for patient with residual invasive disease following this NSCT plus anti-HER2 therapy. So in metastatic settings, the Kadcyla has shown activity in patients who have progressed after chemotherapy or HER2 directed therapy. So this trial was designed to provide evidence for optimizing therapy to Kadcyla for 14 cycle for patient with HER2 positive early breast cancer who have residual disease, invasive disease in the breast cancer or axilla following this neoadjuvant Herceptin containing therapy. So this study design in this patient were the clinically T124, N023 and M0 presentation HER2 positive early breast cancer, and NSCT were applied following this surgery, and in this residual invasive T1 was randomized into 1:1 Herceptin versus the Kadcyla in adjuvant setting. So the primary endpoint were the IDFS excluding second primary non-breast cancer, and the secondary endpoint is the IDFS, DFS, OS, DRFI and cardiac safety as well as overall safety. And so the eligibility criteria, as we have discussed, HER2 positive that was confirmed by the central laboratory, completion of almost 6 cycle chemotherapy and 9 weeks of taxane.
Yes, sorry to interrupt you. Can you be a little faster?
Yes, sir. Within 5 minutes, I have concluded. Yeah. So in this, the well-balanced, the Herceptin versus the Kadcyla, the well-balanced, the trial is matched. So summary, the early breast cancer treatment has a curative intent. Patients should receive the recommended duration of the most efficacious treatment as early as possible to help prevent distant recurrence as well as provide the best chance of cure. So despite this proven benefit of NSCT HER2 targeted treatment, patients with HER2 positive early breast cancer are still at risk of recurrence, particularly those with residual invasive disease. So aim of this trial to investigate whether there is adjuvant Kadcyla improved IDFS compared with this Herceptin in patient with HER2 positive EBC who had residual invasive disease following HER2 targeted neoadjuvant therapy. So the efficacy data, just I will discuss So in this, it met its primary endpoint. So this reduced the risk of an IDFS events by the 50%, as shown in this graph, compared with this Herceptin at a median follow-up for 41 months. So this Kadcyla increased the 3-year IDFS rate from 77 to 88.3%. And all across subgroup, they have benefited. So this efficacy summary, the Catherine met its primary endpoint or almost reduced the risk of an IDFS event by the 50% compared with this Herceptin, and 3 years IDFS was increased by the 11.3%. So this IDFS benefit was shown across all patient subgroup, including hormone receptor status, nodal status, and prior dual HER2 block. And it should not be withheld in patient with HER2 negative residual disease at surgery. So this OS data are immature at this clinical cutoff, with only 98 events have been occurred. So almost safety events well matched. There is a little bit dose discontinuation, and the side effects were thrombocytopenia, deranged LFT, as well as peripheral sensory neuropathy, and ejection fraction decrease slightly more in this Kadcyla group compared with this the Herceptin. So thrombocytopenia, as we all know, that there can be the dose is 3.6 milligram per kilogram, and we can reduce to 3. The second level reduction is the 2.4. So these are well manageable with the dose reduction. Almost side effects are lower side. And the quality of life also well matched. So overall safety data are the consistent with this non-safety profile, and most side effects are low grade, asymptomatic, as well as reversible, and prior platinum therapy are also associated with increased incidence of thrombocytopenia in Kadcyla arm, but didn't affect the duration of resolution of grade 3 to 4 thrombocytopenia, and peripheral neuropathy are also comparable between treatment arms, and the physical as well as cognitive functioning and health related quality of life were maintained over the course of treatment, and it was well tolerated with little impact on this function of or global health related quality of life. So in newly treatment algorithms, if the tumor is 2 or more than 2 centimeter node positive, there is dual HER2 positive agents can be added in this NSCT and surgery. If there is PET CR, so continue this regime. And if there is residual disease, so there is 14 cycle of Kadcyla can be added in the adjuvant setting, or also various guidelines supporting this concept. So summary of this, the early breast cancer has a curative intent, so should receive the most efficacious treatment as early as possible to help prevent distant recurrence and provide the best chance of cure. And Catherine also met its primary endpoint, and it also decreased the recurrence or death by the 50% in the patient. And overall safety data are well consistent with this non-safety profile of Kadcyla. So it is well established in this international guidelines as the recommended adjuvant treatment for patient with any amount of residual invasive disease after HER2 targeted neoadjuvant treatment. And it is also given as a single IV infusion every 3 weeks. Dose is 3.6 milligram per kilogram. First infusion is the 90 minutes and followed by the further in second or third cycle 30 minutes. No loading dose and dose reduction as per guidelines, and patients should be treated until disease progression or manageable toxicity. Thank you.
Dr. Devesh, can I ask a question?
Yes, sir.
So in a triple positive patient, and
Yes, sir.
neoadjuvant Herceptin is given and residual disease is there, and you want to give the TDM1 in the adjuvant setting, how you will club the endocrine therapy concurrent with the TDM1 or after finishing the TDM?
Sir, actually, the benefit was shown in ER/PR negative and HER2 negative patients is more compared with this hormone receptor positive. So there is the no clear data whether in a triple positive patient. If there is the HER2 positive, only HER2 positive patient, there is definite the data. It is showing better. But in this patients, we are not using nowadays regularly. But maybe in future, the data is more and more number in hormone positive patients. So we can apply it. But sir, still is a dilemma in this hormone receptor positive patient.
Thank you.
Thank you, Devesh sir, for your excellent talk. And it was a
Thank you.
wonderful practice-changing webinar today. And as rightfully said in the beginning by Naresh Somani sir and Surendra Beniwal sir, that it was a truly a bias and for us update today. And I again thank Somani sir and organizing team to giving me the opportunity to coordinate the session. And I'll hand over the mic to Pawan Agarwal sir, who's a senior consultant medical oncologist at Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur, to give his closing remarks. Thank you, sir.
Thank you, Ankit. And so good morning, everybody, and even after good afternoon. So first of all, I thanks to Dr. Naresh Somani and his team to conduct this very wonderful meeting on breast cancer. And almost this meeting has designed like a cover each and everything, metastatic, early breast cancer, triple negative, even S2 positive, everything. So if I conclude my thing, so first session has been concluded very well by Dr. G.S. Bhatti on various presentation. And after that, Dr. Sumita Jain, Dr. Raj Govind and Dr. Shantanu has taken care of second session. And it was very different kind of session in which other people has to be share their ideas like redefining the axillary management and skipping the axillary lymph node dissection and giving the radiotherapy. And other thing, intelligent vacuum assisted breast biopsy identify the breast cancer patient. And so new idea has been come up, and it was very well summed up by the Dr. Sunita Jain, Dr. Raj Govind and Dr. Shantanu. And third session, again, Dr. Mukesh Rolania is a extemporia, did a wonderful job. And Uttam Soni has always as a speaker. And Hemant Dadich has concluded again this session very well. And the session 4 and 5, which conducted by the Dr. Hemant Malhotra and Dr. Lalit Mohan Sharma, and in which they clear everything about the triple negative breast cancer from early to metastatic disease, and all questions we have in our mind, and even we have some feeling gap in our mind has been cleared, how much we can look forward to treat them from the very next day. And the last session Deepak Shukla has defined the various various trial about the HR positive, HER2 negative studies, where CDK4/6 inhibitors in various Mona Lisa trial and various other trials, and comparing and how we can choose the right agent to right patient. And later on, Dr. Mukesh Rolania again did a lot of job that has been covered also in panel session. But again, he has elucidated his slide it very well. And last not the least, Dr. Devesh Goyal has presented Catherine trial, and which is, again, his slide is very illustrative and very clear. And I congratulate Devesh especially, that is very good presentation and cover everything. So again, I congratulate to Dr. Naresh Somani team and all presenter, all speakers and all panelists and all moderators for this wonderful session. And by this, I conclude my talk. Thank you, Dr. Naresh Somani. Thank you, everybody. And I wish this kind of a session, this kind of meeting should continue in fortnightly or weekly in future. Thank you.
Thank you, Dr. Pawan, for the nice words and the good gesture. And the idea of this by us and for us was there in my mind since long time. But this time I put down and I said that we will be doing like this only, so that we all come, we all grow, we understand each other, and we get the opportunity to present, to discuss, and to be the speaker and everything. And I think, if not wholly, partly we were successful in this particularly concept. And I hope that we all will be coming forward to have more and more webinar sessions. And I appeal to all of you that now is the time to have the more and more physical meeting. So appeal goes to all of you to come forward, take the lead, and make a meeting to happen very soon in city of Jaipur, and to include and involve all the faculties from across the state of Rajasthan. And with this all, if there is no more comment from anyone else, so I would like to place the vote of thanks on behalf of all of you, because you all are the part of the meeting, to all our sponsors like Elkem, Fresenius, Astra, Novartis, and the Ross. And in the last but not the least, I would like to place on the record the thanks to my good friend, my colleague, Dr. B.S. Ankit, to conduct the session in a flawless manner and to do his job. And I think you all will agree with me that now Dr. Ankit is also ready to be the part of the faculty to have the more and more discussion in the future meetings. And with this all, and if there is no more comments, can we conclude today's meeting?
Thank you, everyone. Thank you so much for the excellent presentation and panel discussion. So we go offline. Good afternoon, everyone.
Thanks. Enjoy your Sunday. Enjoy your Sunday.
Yeah, enjoy your Sunday. So support team, can we go offline and